بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. نمسي عليكم بكل خير. نحن شركة سما الطبية والمعروفة أيضا بالأكاديمية الطبية السعودية، ونرحب بكم في هذا الكورس المهم جدا لنا في حياتنا العلمية والعملية، والمهم أيضا للطلاب والمنسوبين الصحيين لتخصص طب الأسنان وكل من يهمه الأمر ألا وهو التهاب اللثة. وسوف يتم تقديمه عن طريق الدكتورة صاحبة الذوق الرفيع والعلم الرفيع والسمعة الطيبة في مجالها. فنيابة عن الأكاديمية الطبية اسمحوا لي أن أرحب بالدكتورة كوثر. الدكتورة كوثر استشارية جراحة اللثة وزراعة الأسنان، Master of Clinical Dentistry in Periodontal, Membership of the Royal College of Surgeons of Edinburgh. So welcome دكتور كوثر. أهلا بك دكتور كوثر في الأكاديمية الطبية السعودية، والآن أمامك المشتركين. So دكتور, you have the mic now.
Thank you for your nice introduction and for your nice words. السلام عليكم جميعا. أتمنى أنكم تكونوا بخير وبصحة وعافية، وأتمنى أن تعدي هذه الأزمة على خير وتكونوا استفدتوا منها لأقصى حد. اليوم إن شاء الله I'm going to speak about periodontal patients or periodontitis patients. Do we have to treat them or refer them? I know it's a dry topic, so the way I did that, I would present for you some cases, and then throughout the presentation, we will go through the diagnosis and build up on that. So it could be as interactive as possible. If you feel that I'm talking so fast or so slow, or you have any question, you are free to put your comments, and we are happy to follow them. We will stop after each part to get your question, and then we will move to the second part. So we will cover a lot of topics today. We will just review the periodontal anatomy quickly. We will acknowledge what's healthy tissue and how we should manage it, and the diseases and conditions. And we will go through the periodontal classifications and how to diagnose them, the conditions that affect that classification, and how we do the primary care for these patients. Advanced periodontal management, and of course pre-implant conditions. Well, by the end of this presentation, you should know about the periodontal classification. You should know how to diagnose this classification, and what are the management strategies for these patients, and the decisions that you should make on such patients. So hopefully by the end of the presentation, all these objectives would be gathered by you. So this patient can present in any clinic at any time. If you see her, you could panic and see, wow, this is a period case. It has a lot of plaque, it has a lot of inflammation, there is a lot of bleeding on the area, but actually the patient has just supragingival calculus, and by regular screening, she would be fine. It's just gingivitis that could heal well. So the first impression that we take of the patient, it's not necessarily reflecting what's going on within the patient. On the other hand, such cases look perfect. They have the best oral hygiene, they have firm pink gingiva, well-attached tissue, well-keratinized tissue. But then when you go with further examination, what you will find out is the probe will sink into these pockets. There is some severe problems with these patients. So that's the difference between the cases. You can never judge a book by its cover. You can never examine a patient only by looking at it. You have to go through everything in details. It's not enough what we do for the patients by just looking or probing. We need to take x-rays, we need to examine that, because it could give you a different image when you go through it in more details. So periodontology is about examining everything. So if we want to diagnose a periodontal case, we need to have all the knowledge that's related to that case, so we can treat it properly. We cannot just do it by the first look or the first impression to the patient. Having said that, so what we examine really in periodontology, what are the areas that we should know in periodontology? We have actually 4 structures. They are the basics of periodontology. They are the gum, the cementum, the periodontal ligament, and the alveolar bone. These 4 factors, these are the periodontium. These are that's causing the disease and affecting our diagnosis. And diagnosis, actually, we only concentrate on the gums and alveolar bone. For the periodontal ligament and cementum, they are less significant in making a decision. So having said that, what's diagnosis? Diagnosis is to know what's going wrong with the patient. It's not like, oh, I got the correct description. No, it's that you know you got correct what's going on with the patient. So you need really to know very well the gums and the alveolar bone level. And how we can know that? By clinical examination and by x-rays. These two will come together, and then we can add a definitive diagnosis for the patient, and then we can move on for a treatment for such a patient. So on the other hand, on the period disease, if we get the gum has a problem, the bone has a problem, here we can build up with a clinical diagnosis for the patients. So how can we build it? What tools we use them? As I said, we use the x-ray and we use the probe. The probe is the main thing for periodontal patients. You don't tell me that the patient have periodontitis and there is no probe on your table on the clinic. You should measure that. And periodontology, we love math. Everything is by calculation. We measure the attachment level, we measure the clinical attachment loss, we measure the recession, we measure the keratinized tissue, biological width, a number of teeth affected, the severity of the extent and severity of the periodontal disease. So we have a wide range of calculation. You need to be good in math to be good in periodontology, as if plaque indices and bleeding indices are not enough in periodontology. And by the way, there is a new equation as well in the end of this presentation. I will come up to it when we go by the end. It's about the measurement of radiological bone loss. So there is a long list of measurements, and all these measurements, we need to do it to come up with a diagnosis. It's not enough just to look at the case and decide, oh, that's the problem. It's more than that. We need to decide exactly what's going on and the extent of that problem. And as I said before, gums and bone is really the most important issue to diagnose the healthy tissue and the periodontal tissue or the periodontitis tissue. The tissue is the issue. The soft tissue is the issue. The main thing is on perio is pink or the shades of pink. So if any problems happen, you need to notice that. You need to measure that. You need to see how long is the keratinized tissue, the mucogingival junction. So tissue is the issue, and bone sets the tone. If you have low bone, you will have low tissue. If you have bone in normal level, the tissue will just follow the tone of the bone and you will have it. So if there is one thing I would like you to remember from this presentation is these two statements, that the tissue is the issue and the bone sets the tone. Moving up with the presentation. So first, the diagnosis starts from the medical history. You don't start the diagnosis from measuring the pockets or looking at the x-ray, because the medical history will set for you the lines of where to start or where you will take it from. There are many medical conditions that can have a presentation in the oral cavity and affecting the gum. So if you know the medical condition, you would have at least an idea how the gums would look like. There are two major conditions I would like to talk about, and they affect periodontology so much, which is smoking and diabetes. With smoking, patient with smoking, we need to know the amounts that the patient smokes, because it affects their health, it affects their general health, it affects the healing of the gum tissue, it affects the prognosis of the treatment we offer to the patient. So, regarding the smoking, we need to know how much the patient smokes. It's not enough that we know if the patient is a smoker or non-smoker. We need to know more about that. We need to know if the patient is even willing to quit smoking. We need to know if the patient is willing to take the risk to have a treatment and risk it that the treatment will not respond very well of that. So always ask the patient how much they smoke. If they smoke 10 cigarettes a day is the cutting edge. So if they smoke less than 10 cigarettes, so they are in low risk group. But if they smoke more than 10 cigarettes a day, they are in really high risk group. And these you need to take more attention to. Though the low risk, that doesn't mean there is no risk, there is always that risk. but patient needs to be aware of that. So 10 cigarettes, it's the cutting. So you need to know how much the patient smokes. Ask them simply, do you smoke a packet a day or something like this? You need to ask them that because this will affect the treatment and this will affect the diagnosis on the long run. The other thing is diabetes. Diabetes patient, most of them, some of them actually, they are not bothered to tell you they have diabetes because they think you're a dentist. Why would you know about my medical condition? They have multiple periodontal abscesses. They have severe periodontal cases. So diabetes patient, you need to know about their diabetes in more detail. And it's not only important to measure the diabetes on daily basis and they give you, oh, it's 200, it's sitting 180 today. No, you need to know the hemoglobin A1C, which is اللي احنا نسميه التراكمي. دائما نسأل المريض المعدل التراكمي للسكر. This is very important to know. Once we know the accumulative of the diabetes, which is the hemoglobin, HbA1c, this is as well as the cutting edge, which is 7. If the patient tell you, oh, minus 6.5 is always below 7, you are in a good condition. You can treat the patient, you know that you have good results. But once the patient tells you, no, my diabetes is always 8 or more than 7.5, no, these are high risk group. So these will affect your prognosis, this will affect your treatment, this will affect the outcome of the treatment, and actually this will make the disease even worse. So you need to know it very well. I had mentioned these two because these are the most common clinical medical conditions that appear in periodontal clinic. However, there are many other conditions that come in the clinic. Hypertensive patient, and a hypertensive patient as well take medications, and the calcium channel blockers they take, and they cause gingival overgrowth. So we need to know as well their medical histories. There are other conditions. A patient take radiation therapy. When patient come with osteoporosis, you need to know it in more details because patients with osteoporosis take bisphosphonate, and bisphosphonate you cannot extract. So even if tooth, because it might cause bisphosphonate radionecrosis, especially if they taken it IV for a long time. So you need to know exactly what the patient is taking and what the patient is doing. It's not just filling a form and ticking the boxes. It's more about the patients and about the diagnosis and about the long-term prognosis for the patient. So the diagnosis will start with the medical history. And as I said before, diagnosis is about knowing the problem. It's not about ticking a box or saying like, oh, I know that. And now when I will go through the classification, you will see that some description are overlapping. They come in different classification area. We will mention them more than once. That doesn't mean, oh, that's wrong, or you should panic. Oh, which type of classification should I put that under? No, it means you got it right. You just need to have it right to know what's the problem so you can know what's the treatment, because that's the first line of treatment. So medical history is not just about ticking boxes. It's not just about knowing what the patient have and filling the forms. It's more about diagnosis. So here we start off, diabetes, smoking, hypertension. These things you need to really know about them. There are other medical conditions. You can learn about them with time when the patients come with the clinic. Well, not all the cases we know, not all the medication we know. There's a lot of advances in medicine. So we need to be updated and we need to learn every day with every case that comes in the clinic. That doesn't mean, oh, you know the basics, that's fine. No, you will learn more and more as long as patients come to the clinic more and more. And each patient is different and have different medical conditions. So you will know more about them. Moving up, this is typical case that come to the clinic. So the way I will do it now, I will just give you cases. We will go through these cases. If you have more questions, please feel free to talk about them. And then we will discuss the diagnosis and what will come up. This patient is a healthy patient, no bleeding on probing. There is actually no probing depth, but there is all over recession, all over her mouth since she ever know that. It was there since ages. She doesn't even remember when they started. Patient actually main complaint was she wants to start ortho, so they refer her for perio check if she is suitable for ortho. And I'll emphasize on that point a lot during the presentation. Ortho treatment in periodontitis patient could end up really disastrous cases. So it need to have really well monitoring during the ortho treatment. So we need to make a close eye on these patients, not to discharge them immediately. We need to know exactly what's going on with these patients. So when this patient come to the clinic, we examined her. There is literally no signs or symptoms for inflammations. There is no bone loss. However, there is a generalized recession. And as I said, we love math in periodontology. We have a lot of equations to deal with them. But when we measure the clinical attachment level, there is a loss in the clinical attachment level, but there is no pocketing, no inflammation. It's healthy tissue. So it's like a healthy patient that comes in the clinic without any recession. So the only difference is that the periodontal tissue, the gum tissue or the bone tissue is reduced. It's in a lower level. That's what we said. We will diagnose the patient by the gums and the bone. It's in a lower level, but it's in a healthy level. So how can we diagnose this patient? It's healthy, but it has some problems. So we have the first category for the diagnosis. If we have the periodontium intact, where the soft tissue is on the cemento-enamel junction, as you can see, if the soft tissue was here, this would we call it intact periodontium. But here it's a reduced periodontium. Does that mean that this periodontium is not healthy? No, it's healthy gingiva. It's healthy periodontal tissue. It's healthy bone. It's healthy tissue. So we have a clinical health of the gingiva with intact periodontium when it's in the normal level. But when it's in the abnormal level, as we said in the previous slide, it doesn't mean it's not healthy. It just means it's reduced periodontium. So we have clinical gingival health with the reduced periodontium. And we have two reasons these reduced periodontium happening. Either it's a stable case of periodontitis or a non-periodontal patient. What I mean of stable case periodontitis, let's assume that this patient at some point of her life, she had periodontitis and she was treated from periodontitis either by surgery or non-surgical, and she ended up like this and she is feeling happy about it and there is no signs of inflammation. So it's healthy gingival tissue with reduced periodontium for what? For a treated periodontal case. But for example, in this case, the reason for her recession is the aggressive tooth brushing. It's because she brushed her teeth really, really hard. So in this case, it's really healthy periodontium. So in this case, the diagnosis will be clinical gingival health on a reduced periodontium for non-periodontitis patient. And by that, you can build the diagnosis. So it's so easy. I don't need to interfere. We just need to change the toothbrushing habits for the patient. We just need to monitor the patient during the orthodontic treatment. There is nothing periodontally we can do to improve it. We can do gum treatments. We can cover these recessions, but is it worth to do that? When the teeth will move their position, it will change them and it will change the amount of soft tissue. If there is severe loss in some areas, we would prefer to do it with no keratinized tissue, would prefer to do it before orthodontic treatment. But if it's in a minimal 2 or 3 millimeter, it can wait until orthodontic treatment is done. So if the patient doesn't want an ortho treatment and the patient comes to you in the clinic panicking about all the recessions that happen in the case, you don't have to panic and say, oh, I have to refer you to a periodontist, you have a severe problem, you have a periodontal problem. No, just check the health of the tissue. If the tissue are healthy, patient is not willing to do any further treatment, she just wants to make sure that she will not lose her teeth, you can reassure her that she will not lose her teeth and the teeth will stay at that condition. You can explain why these teeth will stay at this condition. You can modify the brushing habits of the patient. And if the patient is willing to take it further and would like to have coverage of these roots, then you have to refer to a periodontist to treat it. Otherwise, you don't need to make a panic attack to the patient, and you should stay calm with these patients. You do not only, oh no, because most of the patients are referred, oh, I'm gonna lose my teeth because the dentist told me my gum is going down with age, and the problem was not diagnosed, it's not periodontitis. On the other hand, having said that, if you are not sure about the cause, refer the patient. Don't try to just reassure all the patient. Always, if you have some doubts about something, just refer it. It's never harm to have a second opinion, but you need to know the basics about it. So you need to stay calm and know it, and with time you will establish the criteria of what the patient wants, what the patient needs, and when I should treat the patient and when I should refer it. So today we'll just put for you the baseline for that, and then you can build on that over time. So this is regarding the first group of classification. Now moving on to the next group of periodontal patients. It's such the patient that I present for you in the really beginning of the presentation. Patients come up with the clinic with a lot of plaque and calculus on the area, poor oral hygiene. Actually, this patient never brushed her teeth. She is 18 years old or 16, and her dentist just panicked when he saw her. She goes like, she has aggressive periodontitis. And when she came to the clinic with proper examination, she actually only have, she only have gingivitis. It's only inflammation. The moment we remove the calculus with regular scaling, the gingiva starts to build again, and after 2 weeks review, everything become firm, pink, healthy. So this is gingivitis case. This is, it's severe form of gingivitis, but still gingivitis. It doesn't have any radiographical bone loss. It doesn't have any pocketing. It does have gingival inflammation, does have slight overgrowth. There is some mucogingival defect, but the moment we remove these plaque and calculus, things get back to the normal. And there is one other thing I would like to add on that point is whenever you are in doubt with patient, always do for the patient some scaling and oral hygiene instructions. They always help. They never harm the patient. They always do good for the patient. There is some issue with the insurance maybe because it might not cover the patient if you're gonna refer them, but it's a good practice that you scale all the patients. I would love to see the patients with clean oral hygiene. And then you will get surprised how much they get improved with only scaling. So always if you have gingivitis cases, do scaling for them, do treatment, do polishing, give them oral hygiene instruction, treat these patients. Don't just refer this patient, put your hand on this patient because these are so rewarding. These are the types of patients, when you treat them, you see the results immediately. The patient will thank you, you change their life, you change their style, and you will feel good. There is nothing could go wrong in these cases. Well, actually, there is always something that could go wrong with these cases. But in such cases, they are so rewarding. They are so simple and easy to treat, these cases. They wouldn't take more than 45 minutes in your clinical time. If you spend 5 minutes for motivational interview and 10 more minutes for oral hygiene instruction, and then you spend the rest of the time and doing the actual treatment, you will end up really good results. And then you will build up really on your patients because once you get their oral hygiene, you can do the fillings, you can do the treatments comfortably. Patient will not come bleed all the time. Main concerns of the patient is always bleeding. Main complaint, they said either sensitivity or bleeding. They never come and complain, oh, we have plaque, or there is some calculus. Well, some of them will come and complain about that when they are really picky about it. But most of the patients, their main complaints is, I have bleeding, I have bad smell in my mouth, I have sensitivity on my teeth. But the rest, they cannot see it. So that's your job to go and treat the rest of it. So you can check the main complaint of the patient. So in other cases, this is exactly the opposite of gingival recession. It's gingival overgrowth, is when the gingiva just puff out. In this case, the patient come in the clinic because she is hypertensive and she takes calcium channel blockers. And because of that, she has her gingiva really, really inflamed. It was over 20 years and nobody had ever diagnosed her. there is multiple periodontal abscesses on the area. And actually, because of the gingival growth, the teeth start moving all around the area because this, the soft tissue is pushing the teeth from the area. This is how strong the gingiva gets in her case. So treating the case for the initial therapy was such a simple case. It was just by changing the medication, writing a letter to her doctor, asking him for change the medication. In such cases, you will definitely refer them for periodontal treatment and management. But as a general dental practitioner, what you can do for these patients, you can kindly write a letter for their doctors because you check the medical history, you know what's causing that problem, and ask them to change their medication to a milder ones or to reduce the dose and give them another medication for it. Actually, her doctor was kind enough to change the medication, and only by scaling and changing the medication, we have really good results, though we had to do for her gingivectomies, but it ended up with really, really good results from the first stage non-surgical treatment. So as I said before, medical history is really important because it has effect. Some patients wouldn't like to go through surgeries. So you need to do something before you go through surgeries, or if you are not going through surgeries, to help the case and treating them. There are some patients who taken as well immunosuppressant. I've just seen a case recently that had liver transplant, and it's present with the same clinical presentation. And the same thing happens with immunosuppressant. There is a drug called tacrolimus. It would reduce the gingival overgrowth in these cases. So we have to ask their doctor if he kindly enough to change it to improve the quality of life of patients. And now the treatment is concerning about the quality of life more than about the results of the treatment or the success of the treatment. Quality of life is really, really important for the patient. Is it worth to treat the case surgically? Is it worth to keep the tooth or to extract it? So this, how much the patient would stay with that tooth, or how long can that tooth stay with that patient? So really, it's all about the quality of life, how we can improve the patient aesthetics, how we can improve the patient function. Patients have pain usually in these cases. So we need to know all these factors to do it. So on this case, as a general practitioner, what you can do, you can write a letter for the patient, do the non-surgical treatment. It wouldn't be ideal. Sometimes you need to give anesthesia to the patient. If you are not sure, always refer the patient. Don't try to be heroic and do some things that you don't really know about it. There are some gingival overgrowth cases that as a general dentist, you can do these cases either by laser or by treatment. I will come later to these cases. But in such severe cases, don't try to do the attempt to do it because sometimes you might, things might go wrong. And then treating the case and getting back to the correct phase of treatment, it will take us a long time. So try to stay confident on the levels of your treatment. You need to know what you know, and then you will move from that. If you don't know, don't treat. If you know that this will help the patient, just do it and justify it. Refer the patient saying, we did non-surgical treatment. It will save even time for the periodontist that would receive the case that, oh, this has been done, so we need to move to the second stage now. And the patient would be happy and would trust you more because you know what you did and you diagnosed them well, and then they will come back to you for the maintenance and review. And then we will come back to the maintenance stage later. As the periodontitis patient will stay periodontitis patient for life. So you need to maintain these patients for life. They will not disappear. It's not just something you did and that's it. You treated the patient forever. No, things doesn't work like that, unfortunately. So the second category is gingivitis. Gingivitis, it could be associated with the biofilm alone, which is as we said in the really first case, it was only by the plaque accumulated on the teeth surfaces. The moment we remove the plaque, the gingivitis just disappear and treated. Okay, it could be mediated by a systemic or local risk factors. And this is from the categories that's overlapping. These are the things that I told you, don't panic about it. Because You may say it in another category, gingivitis related to systemic risk factor, or it's turning out to be periodontitis related to systemic factor. You don't need to worry about it. As long as you diagnose there is a systemic risk factor, you are right. It doesn't have to be in the right box. It has to be in the right and correct diagnosis and correct clinical figure, because that's what will build up on the treatment, and that will you know that, okay, I've done the right thing. A drug-influenced gingival enlargement is, as we said in the patient before, there are many drugs epileptic patients take, hypertensive patient takes, and for immunosuppressive patients, they are influenced the gingival enlargement. And actually, there are other drugs that reduce the salivary flow and causing burning feeling on the mouth. We need to know this medication as well. Definitely, you will not know all the medication in the universe, and always the patient will come up with a new medication that you don't know about. Just Google it, check it. There are always nice location and nice links where you can put the name of the drugs, and they're really accredited. And it will give you all the side effects and the uses of the medication and what they can cause for the mouth. And you need to check this regularly with the patient, and then you're gonna build up on that. If you know the doctors that are referring this patient, you would know what medication they prescribe for the patients. And some of the surgeons as well, I noticed them with the patient with heart problems or anything, when they know that the dentist refer the patient back to them, telling them, oh, listen, this drug using that, they don't use it on all their patients, because they will make a note of it, because, oh, the patient will have problem, and then we will have referred back the patients that we don't want to develop this problem. So it's always a good idea to write back to these doctors, because they can always solve these problems for the patient on the long term. And all the doctors usually are very happy to treat the patients in a way that patients never come back, or let's say will only come back for maintenance or for review appointment. Because as a doctors, we don't want to have the patient complaining all the time. We want to have the patient treated and then maintained all the time. And if there is something that's causing them a problem, we need to solve it from the first side, and then just follow up this to make sure that will never occur again. And another case scenario, we have this patient coming to the clinic complaining of recession on his teeth. There is actually no plaque on the area. There is no calculus, no retentive factors on the area. So it's not plaque induced, it doesn't have a problem. It's not due to tooth brushing, it's due to a habit of the patient. The patient used to work long time in his office, and he used to put his pen on his gingiva, on these two teeth in particular, because he is aware of that habit, and he's the one who informed me about the habit, and he goes like, okay, I've now break that habit, I now want to treat my gingiva. So this is a local factor, this is a periodontal case, but it's not because of plaque induced or calculus induced, it's because of habits, because of developmental factors. So as long as you know the diagnosis, you would know the treatment. So would deep scanning help this patient? No, because the patient doesn't have calculus. The patient is willing to have gingival treatment. He needs to know the risk factor. If he still is on that habit, after we put the gum back in its normal position, it will go back again. But once the patient is aware that and when he breaks that habit, we will put the gum in its position, we can maintain it on that position, then we can go for treatment. So diagnosing the problem is the treatment, is half of the treatment. Solving the problem is the other half of the treatment. So when patients present to your clinic like this, and you examine them very well, you take the medical history, you take their social history, you know their habits, then you can tell the patient, are you willing to break that habit, or did you break that habit somehow? And are you willing to cover this area? If the patient is willing to go through that, then you refer the patient. If the patient says, no, I'm fine, I just want to make sure that I won't lose my tooth, then you just reassure the patient, put them on maintenance program, and see how it goes with the patient. And there is important factors with recession patient. They always worry that the recession goes worse with time. So what can you actually do is take photographs. Photos always help. Take recession measurements. We always love math and measurements. So take these measurements, record them down, take photos, take X-ray. In some cases, you can take study models and keep them for the patient. And then you can really compare. So when the patients come after 1 or 2 years to you back in the clinic and they tell you, oh, listen, my recession becoming worse, then you can compare it of what you really have from their photos, from their probing depth measurements or clinical attachment loss measurements, and from their casts model. And you can reassure the patient, or you can in fact see if it's getting worse or getting better in some cases. So depending on what you see, you can reassure the patient or intervene with the patient. But you shouldn't ignore it. You shouldn't tell the patient, oh, that's fine, you don't have a problem. No, there is a problem, but it's not an issue. So you need to diagnose that problem. You need to acknowledge that there is a problem, but you don't have to intervene with that problem or do something really urgently to it. You can give the patients their treatment options, give them their choices, see what they are willing to do, and take it from there. Never make the patient panic and tell them, oh, it's a really severe case, you need to see it, you're gonna lose your teeth, or underestimate the treatment and tell them, oh, it's nothing though. Just be honest with the patient, tell them that's the problem, what are you willing to do with that, what are the options that doing that. If the patient is willing to explore further option, refer the patient. If the patient says, I'm fine, I don't need anything anymore as long as that it's maintainable and I'm not gonna lose the teeth, you put the patient on maintenance program and you see them regularly. So that's the way you manage it. In another case, patients come with really gingival inflammation and soft tissue proliferation. There is no plaque on this area. Patient actually brushed this area very well because he wants to get rid of this inflammation and infection on the area. And when biopsy is taken to that area, it's really actually just inflamed tissue on that side. So gingival inflammation could be severe and extensive and non-plaque related. There are some cases which has Lupus Erythematosus, like complainers, and all the oral medicine stuff. You need to be aware of them because they could affect the patient's soft tissue in an aggressive way, and the patient doesn't know. In these cases, you should always refer because you never know from clinical diagnosis how bad they are. They could be cancerous patient. They could be so aggressive that they're causing pain and discomfort for the patient. So these cases, always refer. You can, of course, don't scare off the patient. You always tell them, common is common. It's commonly just an inflammation going on the area. We will refer you to someone more expert to explore more on this area and give you more options of the treatment. But don't tell the patient, oh, it could be cancerous, and then the patient will just have panic attack, and then you will just lose the temper in the clinic. Always remember, common is common. Always inflammation, always there is something. And with periodontology, there is always little things that could make a difference. So for example, you would be surprised that a small little tiny of excess cement will cause periodontal abscess. And once you remove it, everything goes back to normal. So it's always about small details, small things that could affect the treatment outcome for the patient. And another case scenario, this patient came to the clinic with a case we call altered passive eruption. When teeth erupt, there are two ways for the teeth to erupt. First, the teeth grow up to stay in contact, and then the gingiva goes up. So in some cases, the teeth goes up, come to the contact, but the gingiva never goes up back to normal. Although the patient has some plaque all over her mouth, but actually her gingival overgrowth is genetic. It's not due to proliferations of the plaque on the area. Because even if we remove this plaque and calculus and all this deposition on the teeth, the gingiva will stay in its position. And that's another key for the diagnosis. If these patients come to you in the clinic, and you can tell the patient, if I'll do for you some scaling, you might get better. And actually she might get better on this and this side because there is some inflammation, but the gingiva will still stay on that level. And then you can say, okay, we're gonna refer you for a periodontist for treatment. In these cases with altered passive eruption, there is always bone down on the area. So actually if they need gingivectomy, they would need full crown lengthening with flap development and bone remodeling on that area. In ortho cases, when they have gingival overgrowth, usually there is no bone underneath it. And you need to measure that to make sure there is no bone. But I'm just giving you as a general rule that you have an idea, but it's not necessary to be that. You need to check the x-ray, you need to have your probing depth measurements. And if it is just soft tissue, as a GP, you can do that. You can do gingivectomy either by laser, taking the proper management, doing stents for the patient. It's nice, providing that you have the training to do that. Don't try to attempt and train yourself on the patient. No, get a proper training, ask about the procedure, read about the procedure, try it in simple cases. I'm sure that most of you have done some sort of gingivectomy when you have class 2, deep class 2 with gingival overgrowth, and you cut it on that area just to have a nice margin and you see probably, or to stop bleeding. So it's the same, just on an extent level. And if you have the proper training for that, it would be really, really nice to do these cases, because these are the type of static cases that will give you the impression what will going on and what's going on that. So this is periodontal case. This should be treated. You can always treat the patient as primary care and remove the plaque and calculus, the staining on the teeth. Patient will always be happy. Some patients actually, once you get the color of their teeth right and their gingiva is firm, they would be happy. They said, okay, I don't want to go through surgery anymore. I'm happy about the results we got now. So you might save the patient from surgery because their main complaint is not the gum, probably their main concern is the teeth. And in periodontitis, although I said we examine only the gum and the bone for diagnosis, but actually we involve the teeth in the diagnosis in terms of recession, in terms of mobility, in terms of vocational involvement, in terms of tooth loss as well in some cases. So you need really to know what the patient wants and then treat it. And as I said, it won't harm the patient to do scaling for them and see how's the response. And actually that will give us an indicator, what will happen next. If the patient will brush their teeth and maintain the oral hygiene, we know that the patient will go through the surgery and will have good results. If the patient keep a very poor oral hygiene, we know the prognosis of the case will not be good, and the patient should be aware of that. And until we establish that, we need to really, really know, is the patient willing to go through that? Then the patient needs to demonstrate that in their oral hygiene. Because if they don't care about their natural teeth, they wouldn't care about what's going next in the condition. So for the second category, we have the gingival disease, but they are not dental biofilm. It's like the genetic or developmental disorder, as I said in the case before, like the altered passive eruption, or in some cases, there are some infection that could cause, or inflammatory or immune condition that could cause that disorders in the gingival tissue. As I said, like implanus, lupus erythematosus, and there are some syndromes as well that could affect the gingival tissue. There is neoplasm that could affect the tissue. Metabolic disorder that's involving the diabetes, as I said, there would be overlapping, but usually this only if the patient have diabetes and gingival problem that's not involving the soft tissue and there is no plaque and calculus on the area. And it's rarely you see such a cases. A traumatic lesion, as the case I showed you before with the habit, with the pen habit, and gingival pigmentation. As you can see here, the patient has as well gingival pigmentation. It's not a problem. It's not due to plaque and calculus. It's just due to genetics. So it's a gingival anomaly that presents on the area. but it's not something we need to interfere about it, or we think that scaling will solve the problem. It's not always that case. A nutritional problem, actually there are few studies that linked nutrition to oral health and oral tissue. One of them is vitamin C with the scurvy disease, and if there is severe loss of vitamin C will cause tooth loss and severe gingival inflammation and loss. Vitamin B12 will always cause burning on the teeth, on the gum and soft tissue oral mucosa. So these need to be put in consideration as well. When you will consider a nutritional anomaly, as if the patient came and they have anorexia or bulimia, or bulimic patient, or there are some patients, like recent days, I see many patients, they just do technique to lose weight. And usually they have really lots of nutritional problems, these patients. And they are really young patients with a nutritional problem. So you can link it to them when you know the medical history, of course. So that's why you need to know the medical history. Some patients wear dentures and you know and they tell you, oh, we don't wear the dentures regularly, and they have burning mouth and infections in the area. So you know there is a nutritional effect because they don't eat really well. So you need to allies as well with a dietitian or a nutritionist, just to make sure, check with your prosthodontist if they can make new denture for the patient, refer the patient to a psychologist if they are bulimic or anorexic. This is the first line of treatment, and actually this might be the only line of treatment because the patient doesn't have any problems, doesn't have any plaque or calculus. The patient may have no loss of attachment. It's just the gingiva have some problem, and that's not related to a dental biofilm. It's related to other factors such as nutrition. So these patients really have to be well diagnosed, because these patients will give you a lot of distress because you will try to do everything to the patient, but nothing works. Where actually what you did is not the right path of the treatment because you haven't diagnosed the problem. And as we said in the beginning, it's not ticking on the boxes and doing all the treatments. It's just knowing what's the problem and treating that problem. That's where the diagnosis comes from. So for the first category, I will summarize it up. We have periodontal health and gingival health. We have gingivitis and we have gingival disease. So the periodontal classification comes in 4 main categories. We just cover up the first category, which is the periodontal health and gingival disease and conditions. And as I said, some of the condition will overlap and come to other classification. You don't need to worry and say, oh, should I put that on the periodontal health or should I put that in the developmental anomalies? You don't need to worry about it. You just need to worry that you know that this is a problem. This is the diagnosis for it, and under which category does this diagnosis come from? It's not much you should panic about it. You need just to know what's the problem is, diagnose it very well as a subcategory, but as a major category, you know that they are overlapping, and you just need to check if there is a disease or there is no disease. So for the periodontal health and gingival health, we cover it up that this is either clinical gingival health with intact periodontium or gingival clinical health with reduced periodontium, which can either be caused by stable periodontitis or non-periodontitis patient, as we said, as toothbrushing habit. And for the second category, the gingivitis with dental biofilm induced, it could be either only with biofilm, only by removing the plaque, everything will go back to the normal, or there could be some systemic conditions that affecting the gingival tissue, or they could be a drug that's influencing the growth of gingival tissue on that area. So these are the subcategories for the main category. So each category have its division. You don't need to worry about it. You just need to know what's the problem with the patient. Okay, for the gingival disease, as we just mentioned, there are a list of developmental and disorders. There is a specific infection that could cause the problem. There is immune condition that could cause the problem. There is reaction process, such as when patient takes drugs or medication, the gingiva will just proliferate on this medication. neoplastic disorder, endocrine nutritional facts, metabolic disorder, traumatic lesions, either by habits or by other traumatic devices, developmental anomalies will come later to explain this, and gingival pigmentations could involve as well amalgam tattoos with the gingival pigmentation, or some systemic disease could cause as well gingival pigmentation. So these are not related to the dental biofilm. So that's the end of the first part of the presentation. If there is any questions or concerns or any issues, or you want me to repeat something, I will stop now to take all your questions, and then we will continue with the presentation. So Mr. Ahmed or Mr. Shiham, if you can hear me, please we'll take.
Yes, السلام عليكم ورحمة الله وبركاته. طبعا دكتورة الشرح كان واضح جدا، بس في بعض التساؤلات. الآن في حالة البريودونتست، هل ما نقدر نقولها إلا لما يكون في بون لوس أو كالسيوم لوس؟
Calcium loss is really not related, but periodontal patients, no, we can say it even without bone loss, only with soft tissue loss. But mainly for the category, yes, bone loss is periodontitis, soft tissue loss is gingivitis. There are some cases with only soft tissue loss, we will put them under the category of gingivitis. Where there is a bone loss, we will put them under the category of periodontitis. That's just the type to explain things. So when you refer the case or speak with other doctors or try to do the treatment, you would know about it. So yes, you can use it as a category, but calcium loss is not something we use it in diagnosis.
Okay, thank you, Doctor. Another question, you said something I should ask first about diabetic patients, something about numbers. Explain it again, please.
Yeah, something about numbers. You need to be good at math to be good at periodontal. I will explain that later as well. In periodontology, we always use measurements. We always use probe. There is a lot of numbers in periodontology, and we have to know these numbers because they give us the extent and severity of the disease. So what are these numbers we are using? We need to measurement. We have first the probing depth, the recession level. Okay, the probing depth is from the gingival margin to the end of the pocket. The recession level is from the cemento-enamel junction to the gingival margin. The clinical attachment loss, which is the measurement from the cemento-enamel junction to the probing, to the pocket depth. So these are linear measurements, and we need to know these measurements on periodontology. There are other measurements as the amount of keratinized tissue. We need to know them. And why is that important? Because if we have 2 millimeters of keratinized tissue around the teeth or around the prosthesis, it will give us long-term stability for the teeth and prosthesis. And if we have less than that, it could cause more gingival disease on the area. So this is another measurement we need to consider. Plaque indices and bleeding indices, there are percentages we need to we need to measure it, because these indices will give us an indication on how the patient will respond to the treatment and what's the oral hygiene habits for the patient. There is other measurements like the extent of the disease. If 30% of the site is affected, or more than 30% of the sites are affected. So these are all numbers in periodontology, and these are all equations. We need to know them to have the correct numbers, to have the correct perspective what's going on. Would they affect the diagnosis? Yes, they will affect the diagnosis. That's why we need to know them to build up on these cases and to know which direction we take these cases from.
Okay, great, Doctor. Another question, how long time need for healing after scoring of periodontitis?
How long?
Time need for healing after scoring.
Well, after scanning, usually I ask the patient to give it 2 weeks, because the first response you will see it, actually the first response you will see it in 2 to 3 days, but then give it 2 weeks just to check the oral hygiene habit for the patient. It takes 6 weeks for the soft tissue to heal, and it takes 2 months for the bone to heal. So if you do just regular scaling and you need to know the response for the treatment, Give the patient 2 weeks to come back for a review. If the patient come back after 2 weeks and he's still complaining or she's still complaining of bleeding on the area, then you need to refer the patient. If they come back after 2 weeks and there is still signs of inflammation, it didn't heal, you need to refer the patient. But if the patient comes back after 2 weeks and everything looks fine, the gingiva goes back to its normal level, there is no signs and symptoms of inflammation, there is no pocketing on the area, patient is not complaining of smell sensitivity or bleeding, then you can just put the patient on maintenance program. So give it a 2 weeks timeline to see how things goes with the scaling.
Okay, another question دكتور. إذا كان المريض عنده نفس الحالة اللي تعرضت أول شيء يعني healthy perio، إيش يكون العلاج فقط؟ هل هو الcorrect teeth brushing أو لازم يروح يقابل الدكتور؟ ممكن تكون الحالة في سن واحدة وصار فيها الريديوس.
صحيح. This is what I said in the beginning. You need to know the reason. إذا patient is aware about the condition. طبعا as a doctor, you need to know the measurements, soft tissue or hard tissue, and then you can reassure the patient. If you see that it's progressing and your patient's coming to you and complaining, then you need to refer the patient. If you see that it's just the habit, the patient stopped the habit, you just can maintain the patient and see it. If you are not sure, always refer the patient. If you are not sure, is it only in one tooth? Should I refer the patient or should I just reassure the patient? As I said, tell the patient common is common. Tell them what's the common thing. Don't make the patient in a panic attack. Tell them, okay, it's common, it could be like this, but I would rather prefer that you have a second opinion. But if you are sure that it's just related to the habit, bone level is good, there is no mobility, there is no sensitivity, there is no inflammation on the area, just keep an eye on the patient and keep it on maintenance program.
Another question دكتور. متى أقول healthy gingivitis وكيف تكون جملة التشخيص؟
جملة التشخيص, it's like as I said before, الحين عندنا مثلا patient with reduced periodontium. تقول patient has healthy clinical gingiva with reduced periodontium. Literally الجمل اللي مكتوبة هنا, these are the diagnoses. These are the things that you should write them as a diagnosis. So if you know that this is the problem, nutritional problem, you would say patient have gingival disease, non-dental biofilm induced due to nutritional problems. If you have, for example, as the patient we saw before, that's non-periodontitis patient, because of the habit of toothbrushing, the diagnosis would be clinical gingival health on reduced periodontium on a non-periodontitis patient due to brushing habits or other habits. So these statements are the diagnosis. So if you have a problem, you need to write these statements, and these are the diagnoses.
Another question, what is the best mouthwash for plaque-induced gingivitis patient?
Well, there is no mouthwash that's the best mouthwash, because periodontitis patient should remove the plaque. Mouthwash doesn't remove the plaque. And this gives the patient the impression that give me just a medication and I would be cured. No, they won't be cured. So if you have, as a doctor, that attitude, I will give you mouthwash, you will get better, the patient will take that impression and he would say, why would I see a doctor? I can get better with medication. So the mouthwash is like a toothpaste. It's something that helps the patient after treatment, but it's not something that helps the patient for the treatment. So the patient have to have the treatment. We can give them the mouthwash to improve, to promote the healing, but we don't give them the mouthwash as, okay, I will refer you to a periodontist, I will give you a mouthwash, antibiotics, and then you can see the doctor. And this is very common, and that happens all the time. It shouldn't be that way, actually. You should remove the plaque, tell the patient, you can use it, it will help you, and the doctor might change it or might ask you to continue about it. But don't give the patient the impression that this mouthwash is the treatment. It's never the treatment.
Okay, doctor, what do you mean by stable periodontist or non-stable periodontist?
A stable periodontitis is patients that have periodontal problem. They lost the soft tissue. There was an inflammation and periodontitis, and we treated them either by surgery or non-surgery. And after we treat them, after maintenance, 3-4 times maintenance over the years, nothing has been changed. So these patients have history of periodontitis, but they are stable. They don't have further inflammation or infection. So this patient, they might come to you and tell you, oh, I used to see a periodontist, they did for me surgery, but now I'm fine. They look clinically fine, but there is a reduced periodontium. So these are stable periodontitis patients. Non-periodontitis patients are the patients that are, as I said before, with the brushing habits. They have reduced periodontium, but they don't have periodontal problem. They never faced that issue. A non-stable periodontitis patient, these are different category. These are periodontitis patients. If someone is non-stable, we told them just periodontitis, and that's have a different classification. So we only classified in a health tissue, stable periodontitis and non-periodontitis.
Okay, another question, Doctor. According to the fourth case, since there is no plaque, how can we treat it?
Yeah, that's what I'm saying. We can treat it surgically. We can cover the issue. The treatment is not only by scaling. The perio is not only by scaling. So we need to correct the bioforms. And when it comes to surgical cases, then you definitely need to refer the patient. So if you see, and we will come up with that later, if you see a patient that has mucogingival defects, recession defects, nutritional defects, they are not plaque related. The patient have excellent oral hygiene. They floss, they brush very well. So in these cases, we refer the patient either to their treating doctors, we refer them to the periodontist for long-term maintenance. They either need surgery or they just need to change their habits and things will go back to the normal. So scaling is the first line of treatment, but it's not always the treatment.
اوكي دكتور، سؤال اخر، اذا كان البيشن يدخن او يعسل مره واحده في الاسبوع، هل هذا يعتبر هاي ريسك؟
صحيح، المعسل او الشيشه is high risk. يعني patient تساله كم سيجاره دخن، احنا قلنا الكت اوف is 10 cigarettes. فالبيشنت يقول لك لا ما ادخن انا، و usually females they said that, and you know what's smoke related, so you tell them كم تدخني باليوم؟ تقول انا ما ادخن اصلا. طيب كم تشيشي؟ مره بالاسبوع، مرتين بالاسبوع كذا يعني. This is high risk because 1 hour of shisha equals at least in the least study 40 cigarettes. This is the least number. Some studies have up to 400 cigarettes a day. So these are definitely high risk. So the moment the patient tells you shisha or معسل once a week, immediately high risk. For cigarettes, you need to know the number. Usually the patients who are at those smoking habits, they will tell you the numbers. Patients with electronic cigarettes يقول لك اوكي ندخن يعني electronic، انا ما اقدر اقول لك النمبر، بس هذا you can estimate it. Actually with smoking there is a certain protocol, you need to follow it with the patients in the clinic. So, but the most important thing is with the medical history, you need to know exactly how much the patient is smoking, because this is the point where you put the patient in a low risk or high risk. So yes, shisha and معسل is definitely high risk. Even once a week, it's high risk.
Okay, doctor. Last question. What is your opinion about Nigeria sativa as adjacent treatment for gingivitis?
Can you repeat the question?
What is your opinion about Nigeria sativa as adjacent treatment for gingivitis?
I didn't get it. As adjacent, what is the treatment they suggest?
As adjacent treatment for gingivitis.
The first part, what's the adjunctive treatment they supposing? They propose.
Nigella sativa.
Sorry, I didn't know.
Nigella sativa.
I don't know about that, to be honest, but any adjunctive treatments, I would like if they could send me later the name of it, I can check it out. But any adjunctive treatment that needs to be examined and literature need to be checked to see how it goes. I'm really sorry. I'm not sure what they meant about it. So they can send it to me. I will give you my contact later and I can check it for them and tell them if it's worth giving the patient as adjunctive treatment or just keep the patient with the regular treatment protocol.
دكتور المقصد من كلامها الحبة السوداء.
Oh, alternative medicine. Well, alternative medicine is a different story. I mean, with old patients, you don't want to upset them. You want them to follow your protocol. So they will always push you with the sorts of remedies they have in their head. But really, you need to be more scientific with the patient. Well, usually what I tell the patient, if they are young patients, I'm very honest and open with them. I tell them, you know, this is alternative medicine. You know, we know what it's work. We know what's in the literature. So please just stick with the medical advice, and I would be more than happy to see the results about it. If it is really an old patient, it depends on how attached they are with the alternative medicine. So you can't just manage the patient and tell her, okay, يا أمي أنا أدري إن هذا العلاج يعني أنت تحبي تستخدميه وكذا، بس أنا أبغاك تستخدمي العلاج اللي أعطيكي أول، وبعدين تقدري تسوي المضمضة اللي أنت تبغيها as long as it's not harmful. اللي أنت تسويها بتساعدك بتحبك, and they will love it and they will listen to every word you would say, and you want that because you want the patient to brush their teeth. So it depends on the mentality of the patient. You cannot just push the patient off and tell them, oh no, this is just rubbish medicine. There is no studies that proves its effectiveness. Well, but you cannot just do that to all the patients. You just need to walk along with the patient until they get from you, trust you, and then they will change it regularly. Then they will say, why I would bother myself and do the home remedy when the doctor gives me something ready? Why would I do that since I brush and things get better? So it's just a way you manage the patients actually.
Okay, doctor. So we finish our questions. So you can continue.
Okay, thank you for the questions. They are really interesting, nice questions. So we'll move on with the second category of diagnosis. These patients come to the clinic with necrotic tissue on the area. The tissue is just necrosis, it's smelly, it lost its texture, it's lost its fill. So this is necrotizing periodontitis. So we are moving now to the periodontitis category. We finished with the gingivitis category. Why? Because as one of your colleagues just asked, there is bone loss on the area. The moment is there bone loss on the area, we will move on to the second category for the periodontal classification. So it's a periodontitis. It has some bone loss, it has soft tissue loss, it has some swell on the area. So it could be generalized or it could be localized as such in this case. Actually, the cause of this case, patient did put some medication, so it was a sort of chemical burn, and then it just got worse, and the gingiva just died, and it had some sutures on the area where it cuts the blood supply. It was a long story with this patient where it ended up with necrotic tissue on that side. Abscesses, periodontal and abscesses. So abscesses are really, really common in periodontal patients. Periodontal abscesses are diagnosed that they are only on the soft tissue. They are not related to the tooth. And in diabetic patients, it could be generalized all over the mouth. So if the patient has sinus, we can track it with a guttapercha. If the guttapercha goes back to the root, we know it's something related to the endo. If it's just to the soft tissue, it's soft tissue. It's really confusing when the patient have large filling on the tooth. But if the patient have no fillings on the teeth, you can immediately diagnose it as a periodontal abscess. The cutting point between periodontal and endodontic abscesses is tooth vitality. Always check the vitality of the tooth. If you are in doubt, check the vitality. Do you need to have a second opinion in these cases? Yes. Does the scaling help in these cases? Yes. Because sometimes what causes periodontal abscess is really a small, tiny amount of calculus or some cements, some excess cements, or some filling that's on the area, or sometimes patients just eat popcorn and the remaining of it stuck between the teeth and they cause periodontal abscess. And it's actually really common on that side. And patient will come in severe pain and it's painful. And you would be surprised how small things really cause severe pain for the patient. Periodontal abscess could be just to drain and scaled treatment. And sometimes we have to open a flap to clean it really well and remove all the disease on the area. It depends on how deep it is. Such in this case, I had to remove flap because it was really deep. I couldn't reach that area just by deep scaling. So we just open it, drain the abscess, and treat the area. Perioendo lesion are a common category of periodontitis. Previously, in previous classification, when you read the old papers, you would see that there is perioendo, primary endo, or primary perio. But now in the new classification, they try to make things as easy and as simple as it is. So if patient have endodontic lesion and they have periodontal issue, it's just a perioendo lesion. If tooth is vital, it's a periodontal lesion. If tooth is non-vital, it's an endodontic lesion. You don't need to go through it. If the tooth have both problems, it's just perioendo lesion. So that's simple. And as I said, it's always the vitality test that determines what it is. Do you have to refer these patients? Yes, definitely you have to refer these patients because there is a certain treatment protocol for these patients. You don't want just to treat it. And some teeth are really vital. And with the periodontal surgery, when you go to the apices, the teeth become non-vital. And then during the treatment, you need to refer them to endo. And sometimes in some cases, when I open the flap and I see bone loss until the apice and the tooth is still vital, I would ask the endo to do for me an elective endodontic treatment just to save that tooth. So perioendo lesion, you need to refer them because they are complex. Well, usually what I ask you now in the periodontitis category, complex cases or cases that needs multi-speciality, always refer them. It would be nice if you get involved and follow up the patient so you know how the treatment goes on and how successful would be the treatment, because at the end of the point, the patient will come to you to review and to follow up. But you need to know how things are going on. But please refer these patients because it will give us on the long term the results. They need multiple times for follow-up. There are many communication between perio and endo. We have accessory canals, dentinal tubules, and the apice. On these three sides, the periodontal ligament is attached to the pulp area. So either of these three entry, they could affect the pulp, the endo in any way. And usually if patients have furcation involvement, the furcation contains like 30% of accessory canals on the area. So if the patient have like grade 3 furcation and severe periodontitis, they would probably have some delayed response in the pulp or some non-vitality in the pulp. And then you need to wait, is it worth saving the tooth? What can we do to save the tooth? Why would we save the tooth as a strategic? Or is the patient so attached to the teeth? So these cases get really tricky. And always when we decide, should we save the tooth or extract the tooth, take a second opinion. Even I, as a periodontist, when I want to extract a tooth, for whatever reason, I would take a second opinion because you don't want to lose a tooth. It's not an easy decision to make. So always, well, I'm not talking about the definitely hopeless teeth. I'm talking about the tooth with questionable prognosis, because can we do something for the patient? And there is always a golden rule. You need to keep it in mind, which is how much is the patient attached to their tooth? If the patient really wants to keep the tooth and they will pay whatever it takes to keep that tooth, and they are willing to take the risks, even if they have a low outcome, help the patient with it. But if the patient is really not attached to their tooth and they will say, okay, you're gonna do for me all this treatment, and then you tell me by the end of the day, I might lose the tooth. Let me lose it from the beginning and give me the alternative treatment option. So you need to be very careful to assess these cases. You need to check the risk benefits. You need to give them really a detailed treatment plan in these cases. It's not a simple case that it's just go through by it. It's really complicated. It's multidisciplinary cases. Always take a second opinion in these cases. Always refer these cases. Keep involved in these cases, especially if you know that they're gonna come back and follow up, because you need to know what happened to the patient. Once you know what patient goes through, you can be more passionate about the patient, you can know what the patient is going through. But just don't break in the middle and then the patient comes to you after 1 year and he tells you the story and you go, oh, really? You had to do undo? No, you should know that. You don't need to know that from the patient, okay? Because the patient feels happy if you know that you are following up with them. So they will know like, oh, my doctor is amazing. He knows what I've done, and they will always come back to you. They will refer their relatives to you. So that will be a good point to do that. So these are with periodontal abscesses, and we covered as well the periodontal lesion at this category. This is a typical periodontitis case. These cases of periodontitis, you would see them on everyday basis, where they have inflammation, recessions, plaque and calculus, tooth loss, frication involvement, teeth mobility. These are typical periodontitis cases. The classification of these periodontitis cases, these come with stages and grades. I will explain them in a simple way later, but I don't want you to get confused. So we'll just keep it now with the bigger picture. So these are periodontitis cases. As long as we classify these periodontitis cases, because they have bone loss, deep pockets, attachment level loss, clinical attachment loss, mobility, tooth loss, it's definitely a periodontitis. Once we diagnosed it's a periodontitis, then we move to the other point, which is with the other stage and grade for the periodontitis. المرحلة والدرجة للبيريدونتايتس تجي تالي، بس التشخيص الأساسي هو periodontitis. فأنت لما تيجي تشخص البيشنت لازم تقول it's a periodontitis case. You do the numbers as we said from the beginning. Is it generalized more than 30% or is it just localized? Is it just in some area or it's in general area? That will give us the extent and severity. But the most important thing is the diagnosis. It's the problem. You need to know where the problem is. Once you know that's the problem, then you can go in more details on the problem. But don't worry about the other details. What should I do in the stages and grade? Because these are additional information that give you additional clue later on. I will explain them in the last part of this presentation. But don't worry about it. As I said, diagnosis is half of the treatment. If you know that this is the problem, you can manage it. And then depends on the severity of that case, I would ask you to refer it or treat the patient. Usually, moderate to severe cases, I would definitely ask you to refer the patient. Don't try to attempt and be heroic on that. I would always love to see a patient with excellent oral hygiene. If you just give them some oral hygiene habits and do some gross caring for this patient. But as a treatment, they definitely need really extensive treatment. These patients, you can tell them, okay, I will do for you scaling. The scaling will not work. I will give you mouthwash with the scaling I did. It will help you a little bit until you get your appointment. But don't give the patient the medication and antibiotic as the treatment option. It's not a treatment. Don't tell the patient, okay, you are periodontitis case, you have a lot of inflammation, I will give you antibiotic mouthwash and go and see your periodontist. No, you either don't do anything to the patient, don't over-medicate the patient, just refer the patient, or if you want to give the patient some medication, do for them some scaling. Drain the abscesses, do gross debridements, give them oral hygiene habits. Unless there is like really big infection on the area and you have drained it and you think it will not heal by its own, then you need to make the decision for giving the patient some medication. But don't give the patient impression that this medication will cure you, because once the patient feels better about it, they will never treat the patient. They will always come back to the doctor and tell them, okay, why you don't give me just medication like the other doctor and I will be fine. They will never be fine, because you will just make things harder for the other doctors to convince the patient for the for the best treatment to have. So in this category, this is periodontitis. And the first category was gingivitis only. So periodontitis, we have necrotizing periodontal disease, which could be generalized or localized. Localized is 30% of the site affected, generalized when it's more than 30% of the sites affected. Okay, we have periodontitis, which I said to you, it could be with stages and grades that we will explain it later. And we have the periodontitis as manifestation of systemic disease. And this is different than the gingivitis, and that's what one of your colleagues had asked before. When we put it under gingivitis, when there is no bone loss, but when the patient is diabetes and have bone loss, we will put it under periodontitis as a manifestation of systemic disease. And we will have stage and grade because it's periodontitis as well. So all these categories, when we diagnose them, you put on the diagnosis as it's necrotizing periodontal disease, stage X, grade Y. We will explain these stages later on. But what I really want you to know is the main diagnosis, and then the stages and grade, we can add them later on upon the diagnosis. So if patient is diabetes, for example, if this patient I've just shown you is diabetic and he has periodontitis, so the diagnosis will be periodontitis as a manifestation of systemic disease, and then you will add the stage and the grade on. If the patient has periodontal abscess or an endoperiodontal lesion, you put the diagnosis as periodontitis with periodontal abscesses or with a periodontal lesion with the stage X and grade Y. So this is the diagnosis. This is the main category we need to diagnose them. Once we diagnose that right, then we move on to the next step. So we have the periodontitis as a second classification. The first classification was the gingivitis with its category. Now, these are the periodontitis, necrotizing periodontal disease, periodontitis, periodontitis as manifestation of systemic disease, and periodontal abscesses and endodontic periodontic lesion. Okay, now we come to the periodeformities with gingivitis. We have some gingival defects that happen. These defects could or could not come with bone loss. And as I said before, you always need, you don't have to worry if it is under which category. Do I have it through only gingival defects, or is it periodontitis with gingival defects? As long as you diagnose the problem properly. So if you have recessions on the area, you would know what's the problem on the area. The gingival tissue needs to be examined. There are several ways to examine the gingival tissue. As I said before, we examine the keratinized tissue, and the amount of keratinized tissue, we just put the probe on the area and we measure the distance. We can examine the thickness of the gingiva, where we insert the probe inside the pocket and we see how thick the gingiva is. If the gingiva is, if the probe, we can see it through the gingiva, this is a thin gingival phenotype. If we don't see it through, it's a thick gingival phenotype. Phenotype is the new terminology we use it. On previous paper, there were difference between phenotype and biotype, and they both explain the same thickness of the gingiva. But now with the new classification, we only say phenotype. So all the recent papers that came up after 2019, they all said phenotype, phenotype. But if you read a paper that's before that date, there would be some biotype, but they mean the same. So phenotype or biotype give us the indication, the thickness of the gingiva. So if we diagnose the gingiva as a thick tissue, it's a thick phenotype. If there is a thin, it's a thin phenotype on that area. And there are two ways to examine this. The first way is to examine it, is to put the probe inside the gingiva and see if we can see the probe through or not. If the probe is inside and we cannot see the probe, this is thick gingiva. If we can see it, it's a thin gingiva. The other way to do it, you need to numb the patient. You cannot do it without giving the patient anesthesia. And it's actually aggressive way. It's like putting the probe perpendicular on the gingiva and see how thick it is directly. Well, it's called bone sounding as well. It is a bit aggressive. We do it only in the cases where we're gonna do gingivectomy and cut the tissue to do as a bleeding point or marking point on the area. You don't have to do it in all cases. You can just put the probe. You are putting the probe anyway to check the pocket depth. And while you are checking the pocket depth, you can check how thick the gingiva is. What's the clinical indication? What benefit would add to me if I know if the gingiva is thick or thin? You would know if the gingiva is thin the patient will be more prone to recession, will be at more risk factors during surgery. It's a risk factor if it is a thin, actually. So you would know that if patient will be exposed to any problem, the problem will be aggregated. With the patient with thick tissue biotype, that means that you will get away with a lot of things. If you do surgeries for the patient, you would know that the outcome will be great. The recession risk is low. And as I said before, in the category of gingivitis, if you have patient with ortho and you want to do gingivectomy and you have the proper training to do the gingivectomy, check the tissue. If it has thick biotype, you can do it. Even if things go wrong, they don't go bad. But if they have thin biotype, don't try to attempt it. Refer to someone more specialist unless you have the proper training for it. So this is the area where you can see, can I manage it or not? For example, if you have a deep class 2 restoration and the patient is thin biotype, and then you decided, okay, with the burr, I will just remove the tissue, it will end up disastrous in most of the cases. But if you have a thick biotype tissue and the bone is away and you just want to remove a little bit of the tissue to have a proper access, then you can do it. So this is the way you can measure it. It is a good way to do it. You need to know it because it has some clinical indication on that area. So moving on from phenotype, it's the recession. It's another gingival anomaly. Here you can see it's a thin phenotype because I can see the proponent, and that led to recession for the patient on several areas. So recession is a dental anomaly. Phenotype is a dental anomaly. The good thing is we have keratinized tissue here. So this is the mucogingival line. And as I told you, we like measurements here. So we have here 2 to 3 millimeter of keratinized tissue. That's good. That will give us a good indication. If we don't have keratinized tissue and the mucogingival line is even higher more, that's even more risk for the patient. So we need to know our measurements because we need to know, is it worth to go to the treatment or not? And as I said, if you are not sure, always refer the patient. Another dental anomaly is the vestibular depth. Actually, there is a lot of things going on in this case. This is the vestibule of the patient. Shallow vestibular depth is as well as risk because the vestibule has many frenal attachments or many muscular attachment and tendons. And these here will pull the tissue and cause more recession for it. So if we do deepening of the vestibule or frenectomy on that area, it will help us to treat the recession. So, but if we keep it like this and we tell the patient, oh, you will be fine, and you haven't diagnosed that, the patient will come back later to you and will tell you, oh, things are getting worse. So as I said, diagnosis is half of the treatment or half of the management. So if you see a shallow vestibule, refer the patient, tell them, okay, you need more treatment or you need an eye to be taken on that. But if it's really, really deep vestibule in the area and a good keratinized tissue, a thick biotype, then you can reassure the patient. Thin biotype, shallow vestibule, recession already done, damage is already done, refer the patient. So you need just to put all the picture together, diagnose it, and do it. You need to do it all. Yes, you need to do it all. You need to take x-rays. You need to check it all. It's not enough just to see it clinically. Yeah, okay, you brush your teeth very well. There is no plaque. You are fine. You should be fine by. No, this is not the way how it works. Periodontitis is something you need to take care of the gum, of the periodontal tissue, of the bone, and you need to put it all together to come up with the diagnosis. One thing is not enough. Everything should come together to have a proper and decent outcome for the treatment. So another anomaly, if you remember the patient, I told you that he have a habit of putting a pen in his teeth and he developed recession. It's not necessarily a pen, it's a developmental anomaly. Patients with PERS, with tank PERS, will have really severe recession, especially on the lower anterior lingual side. So you need to know that the cause of this is not periodontitis. Though the patient doesn't have really good oral hygiene, but it's a factor that's add on it, but it's not the main cause for it. So The main cause was that, the aggregating factor, and then there are other factors that add to it. If the patient have like persis or even lip persis, will cause recession on the buccal side of the teeth. So if the patient have these and they said we would like to do some root coverage surgeries, I'll tell the patient simply, as long as you have this purse, I will do for you the surgery. You will go through a surgery. You will go through the pain of the surgery, and then it will come back again because the causative factor is there. And in addition to that, if the patient has poor oral hygiene with all these problems, they will just add up on it and will make it even worse. So it's not even bad enough to have some pus on the area. It's the periodontitis will make things worse. Even it's with all the categories actually. Even with the non-biofilm induced diseases, if the patient have these diseases and they are non-biofilm induced, but then they have the biofilm on the area, they will just make things worse. So that's why worse caring will come help. But let's assume that this patient have excellent oral hygiene and he still have recession. What would be the treatment? We can do coverage for the patient. On the lingual side, the studies are in between. Is it worth doing it? Is it aesthetic? Is it for function? Is it for sensitivity? And as long as the factor is there, there is really nothing much we can do, because even if we did the best and the most excellent root coverage surgery with 100% root coverage, there is still a risk factor that will cause it back again. So until the patients stop their habits or change their habits or remove their purses, there is not much more we can do for it. So someone might ask, is it worth doing it as the patient is worried that it might get worse because the patient doesn't want to remove the purse, but he wants to keep his teeth as well. Well, as long as the patient understands that if we do the surgery, it might come, it might go back to the same situation, yes, we can do that for them. But if the patient is not willing to take the risk because he thinks that what's the point of just repeating the surgery or doing the surgery all over again, then that's a different story. I have some patient which comes to me every 2 years for recession coverage because they have a habit, and it takes from them 2 years until they get to the 5mm recession, and then they want to bring it back to normal. And it's so funny that they know exactly the measurements for the recession, and she is so aware that it's because of the habit, but she decided, I will not break my habit and I don't want to get my tooth worse. So I just wanted, the threshold for her was the 5mm recession, and I just wanted to repeat it every 2 years. As long as she understands that, and every time I try to explain that for her, and I tried different modality for her, but we'll see what's happening now in the next 2 years. But yeah, but these things are occurring all the time. These things, you need to inform the patient before referring the patient so they have clue what's going on in their mouth. And then from there, you can build up on the patient and tell them. But for the diagnosis, it's a developmental anomaly that's causing a problem for the patient. It's acquired anomaly because it's something we added on the patient and it's causing the problem. Even developmental anomalies, it's like if the patient have enamel peel on the tooth, and sometimes they have it over here and it end up with the recession, we can just remove the enamel peel on the area and it will get them better. So what are the mucogingival deformities and condition about the teeth? The mucogingival deformities are, that happens in the pink only. It is an periodontitis category. That's where someone says, do I have to have bone loss? You don't have to have bone loss, because in these cases, these are periodontitis cases with the mucogingival deformities and anomalies of the cases. And you need to check the gingival phenotype, as we said before, if it is thin or thick. The soft tissue, if there is a recession, or we might say other problems with that soft tissue. Lack of gingiva, there is no gingiva, no keratinized gingiva at all. Decreased vestibular width, the freedom attachment or the muscular attachment on the area, as opposing of the recession, gingival excess or overgrowth of the gingiva. So Why are these in the periodontitis category, not in the gingivitis category? These have here some bone loss related to the area. Abnormal color, it doesn't necessarily have bone loss on the area, then it would be related to the gingival disease, where I said it's as a amalgam tattoo or genetic gingival pigmentation or genetic color. Abnormal color, like amalgam tattoo, when there is a really big punch of amalgam that's in the pocket, it might color the gingiva and lose the tissue around it and lose the bone around it. This would be considered as an anomaly with the periodontitis. So, and there are some conditions that would expose the root surfaces, as I said, the acquired anomalies, enamel pearls, or other conditions. So there are many factors that could cause it, and these are all overlapping. You would see some of these factors in another category of, or subcategory of periodontitis classification. Don't worry about the subcategories as long as you got the main diagnosis correct. So this case, another case, moving on with periodontitis cases. This case is ended up with periodontitis here. There is a pocket, there is an inflammation, but there is no plaque or calculus whatsoever in the case. The patient has excellent oral hygiene. These cases you definitely need to refer. It's not something that the scaling will solve that problem. There is an occlusal problem. With periodontal patient, we have occlusal trauma, and that could cause, this is primary occlusal trauma because the patient have normal periodontium, and because of the continuous trauma on this tooth, it's causing them periodontal pocket. Secondary occlusal trauma, if the patient have reduced periodontium, and because the teeth are weak, then with normal forces, they will have the trauma. So this is primary occlusal trauma. There is no problem, but because of the strong trauma on that tooth it has. The treatment of these cases will first relieve the teeth from the occlusion, manage the case properly, and then refer to orthodontic or prosthodontic to adjust the teeth and prepare them. And as I said before, when referring these cases of orthodontic, they need really to have a close eye with the periodontist, because you don't want just to refer them because they could end up as a disaster cases and they might lose the teeth. So they need to be monitored really, really carefully. An excellent orthodontist need to look at these cases, and I'm lucky to work with the best orthodontist in the area just to see how things are working around this area, and then we need to monitor them properly, because this will not work on its own. This will not succeed on its own. It has to have multidisciplinary action on that area taken. And as I said before, any multidisciplinary cases, just refer them and follow up the patient. Don't try to be heroic in these cases, because you might think that you are helping the patient, but you actually make things worse. So just refer the patient, follow up the patient. If there is something you can do, we'll definitely let you know to do it for the patient, but please don't intervene with these cases, because these cases will need really close monitoring. So, orthoperio anomalies, they may cause recessions. They have recession. Well, actually, this patient have really good ortho done, and she is just referred to have the root coverage surgery on the area, of course, with frenal attachment, because this is another anomaly. Orthoperio patients, I don't know from where I start. If they are not managed well, if they have a lot of plaques and calculus on the area, they end up a disaster. You need to keep a really close eye to these patients. There are more and more cases that coming up that they've done ortho with forces, because if you remember what I told you about the occlusal forces, even if the patient have normal intact periodontium or reduced periodontium, and then the forces exceeding the tolerance of the periodontal level, it will be a disaster. The patient will have breakdown for all the periodontal ligament, breakdown for all the tissue, and the tooth become loose, and the patient could lose all their teeth. So the forces need to be studied very well. The amount of forces depends on the periodontal condition, needs to be studied very well. The oral hygiene will affect it, because if the patient have oral hygiene, even with the regular forces that use, but because they have a bad oral hygiene, the periodontium is weak, so the forces become stronger and the condition become worse. So with these patients, we need to be really, really, really careful and not to go and say, okay, you can have your ortho, you can do your scaling after you finish the ortho. No, this doesn't work like this. It could be a disastrous, could end in a catastrophic way, unfortunately. So either the patient is having the issues before the ortho treatment or during the ortho treatment. After the ortho treatment, damage is done, game over. There's nothing much we can do for the patient. But during ortho treatment, we might grasp on whatever remaining and save the rest of the periodontitis. So for this category, we have here traumatic occlusal forces, primary occlusal trauma, secondary occlusal trauma, and orthodontic forces. And these are all periodontal cases. And please, these cases refer immediately without any delay, ASAP, because these can end up really, really badly, which I mean by badly losing the tooth. The moment we lose the tooth, that's it. We end up with a different category. So the last category is prosthodont. Some prosthodontists can do, or some dentists, well, I'm sad to name them as dentists, can do some treatment as inadequate as that, and it's really affecting the gingiva and the tissue. And then what they tell the patient, okay, go to the periodontist to solve your problem. So it's not a periodontal problem, it's a prosthodontic problem in the first case. And it could be as severe as multiple teeth, and it could be as one tooth with a really bad filling on the area. So this area, refer immediately. The patient should definitely see another prosthodontist to see the treatment. And they could come as severe as these cases, or they could come as these cases. These cases, usually the patient paid a lot of money for their crowns and Hollywood smile or whatever is that, but unfortunately, because they didn't have crown lengthening, they didn't take the measurements, and they didn't have the number rights for them, they end up with severe gingival inflammation on the area. And these cases are really difficult to inform them that to treat them properly, we definitely need to remove this prosthesis at some point and re-establish the biological width for the tissue to have a proper development. And if you tell the patient, I will treat your gingiva, I'll do for you crown lengthening without removing these teeth or keeping them as a temporaries, the patient might agree, but you need to inform them they might end up with a recessions, and patients usually don't love recession. So if the patient tell you, okay, I will change my crowns in 2 months, but I want to do the perio treatment, I'll tell the patient, okay, we'll use your crowns as a temporary. We'll do all the studies we need. We do all the surgeries. We do prosthetic assessment, wax up, or digital analysis for the patient. And after we finish all that, we can do the crown lengthening for the patient. Patient understand the risks of recession. Patient should understand the risk of there would be more difficult cleaning on the area. And then we can cut this crown and place temporary. But what I like to do in these cases is, unless the patient is sure about the treatment, I would prefer to have the temporaries ready done after the surgery immediately, because if we have nice temporary and after the crown lengthening surgery or after the perio surgery, they will take the margin of the temporary. And if you have a really good prosthodontist, they usually do the margins very nicely, then your soft tissue will heal really nicely around these teeth, and you end up with really, really amazing results. So these are the most, actually, these are the most difficult patients to treat because they paid a lot of money to treat their teeth. Their teeth are genuinely fine with the color, texture, shape, and everything. And it's hard to convince them that we will remove what makes you really happy and what improved your quality of life and what helped you, because it's not healthy. The way it's done just for a shape, but not for a health. So these need to have careful consideration. Please, please, please refer this patient immediately, because these are multidisciplinary cases. There is nothing much to do with these cases, and they need an attention and treatment to be done for that. So for this categories, prosthetic related factors, or there is plaque predisposing, as I said, When there is plaque, things will go even worse. When there is no plaque, the problem will be still there because there is a prosthetic on the area that's not done well. And it could be localized by one filling over hanged restoration or with poor margin restoration, or it could be like on a prosthetic related factor for the whole prosthesis. So for the last category, to summarize it up, it's a periodontal manifestation, which is the third category. The first one was gingivitis. The second one was periodontitis. The third one is periodontal manifestation as systemic disease, developmental or acquired anomalies. So that improved the systemic condition that affects the supporting tissue. And as I told you, it might overlap. No worries about the overlapping. Just worry that you have the correct diagnosis on the area, the mucogingival deformities and condition on the area, if there is traumatic occlusal forces, and if there is tooth and prosthesis related factor. So by that, we covered all the periodontal categories, and this is the second part of the presentation. I would stop here. If you got any questions or concerns, I'm more than happy to clarify and answer all your questions. Please, Doctor, if you have the questions.
شكرا دكتورة على الشرح الرهيب. طبعا في بعض الاستفسارات وصلتني في المحاضرة. In case of endoperiorations, does draining from access cavity enough for perio abscesses?
Usually it's not enough. It helps, but it's not enough. But definitely drainage help anyway. If it is a perio abscess and we have endo lesion, so the way we treat it is we treat initially the perio, we drain it from perio and then refer it to endo. And before the final treatment for endo, if the patient needs a perio surgery, I would do it. Always endo helps because if they drain through the access and treat it, it would be nice. But you know, the pulp channels are really, really thin, tiny. So usually not all the abscess coming out through it. So the periodontal is already compromised. So there is no harm if we just open the periodontal tissue and clean it all. So it's, as I said before, it's the sequence of treatment. What should be treated first? If the patient has severe symptoms, in some cases, if I got the chance, I would do it at the same day. I will just drain the abscesses, clean the patient, give them antibiotic, refer them to endodontist, and the endodontist will start the initial treatment for it, remove the pulp chamber and the diseased tissue, remove whatever abscess that comes from the pulp, put some medication to that, and then the patient will come to periodontal assessment. And once things are stable again, we will refer them for final endo treatment.
How can I know if it's perioindulations or endoperiorations?
It doesn't matter this time. Before, we are really obsessed to know which comes first. But with the new classification, really you don't need to worry about it. As long as there is perioendo lesion, it's a perioendo lesion. But you need to make in mind, if the patient is diabetic and they have periodontal abscesses, you know it's a periodontal problem. If the patient have it in a single tooth and there is some factors related to it, you know that's an endodontic lesion. But is the egg from the chicken or is the chicken from the egg? That doesn't matter really. What matters is there is a problem, and that's what they try to make it easier with this classification. Perioendo lesion, it's perioendo lesion. What comes first, it's not really important. Both has to be treated properly.
What is the diagnosis if the patient has gingival recession?
Then we would say the patient have reduced, if the patient have gingival recession with healthy tissue, then we said reduced gingival health with stable periodontium for whatever cause it is, stable periodontitis or non-treated periodontitis. So we covered that already in the first part. So if the patient have gingival recession with bone loss and active periodontal disease, like the gingival margin is inflamed, it's gingival recession, periodontitis with gingival recession.
Is the thin and thick gingival matter in how does it healthy?
Yes, I just explained that. It matters because it gives us the prognosis of the treatment. It gives us our limitation. If it is thin, it's more prone to recede. If it is thick, it will give us better outcome on the long term. If it's thin, we might tell the patient from the beginning, we will do for you free gingival graft. If it is thick, we can get away with it, to be honest with that. And we get away with a lot in periodontal. So it's important to know. And yes, it matters because if the patient have thin phenotype and he comes to your clinic and tell you, I feel my recession is getting worse, you will expect that his recession is getting worse and you need to refer the patient immediately. But if the patient is coming with a thick biotype and the patient tell you, I'm worried that my recession is getting worse, you can just keep the records, as we said, take the probing depth, photos, cast models, and keep an eye on the patient and follow up the patient. If you really feel it's getting worse, you refer it. If not, you just keep an eye on it.
What is the difference between true and false or pseudo pocket depth?
Between true and false what?
Pseudo pocket depth.
There is no much difference on that in terms of how you will treat it. The true pocket depth is that the gingival margin is either at the cemento-enamel junction or below the cemento-enamel junction. So you will just go there and it's the same measurement. You measure it from the gingival margin to the pocket depth. So that's the normal. The pseudo pockets, you would say that the patient have pockets, but actually the patient doesn't have pockets. Why? Because the gingiva is overgrown. So what I said, it doesn't matter because it's the same way you measure it from the gingival margin to the base of the pocket. But it's not really a true pocket, full pocket, because the gingiva is grown. It's not from the cemento-enamel junction. And then you have to calculate the difference. How much until the cemento-enamel junction, how much is pseudo and how much is true. And that's where the treatment will need to come through it. So it's the same way of measuring it. It's just the way that it's false or true on it. In my opinion, a pocket is a pocket. Either it's pseudo or it's true pocket. It's just a matter, if it is overgrowth, it's even worse. It's not better because we said, oh, half of it is not true because it's above the cemento-enamel junction. That means the patient have other problem to worry about it. So we need to address all these issues altogether.
Will gum recession be returned to normal level after good oral hygiene?
Some studies said up to 1 millimeter. Definitely if the recession is due to some factors like prosthesis. Sometimes the moment we remove the prosthesis, we do the scanning, they go to their normal level, but usually no. In these cases, I wouldn't raise my hope. I will hope for the best, but expect the worst. So yes, they might come back, but it's not something we will definitely say, okay, we'll wait and see how it goes. So we might remove the defective restoration where there's recession. The gum will go back to normal, yes. In some orthodontic cases, if there is a recession due to the tooth position, once we put the tooth back in its normal position, the gum will grow back to its normal position, yes. In some cases with the calculus-related factors, it's the same as prosthetic-related factors. Once we remove it, the gum will go to their normal position. If you remember what I said from the beginning, bone sets the tone. So if you have good bone on the area, the tissue will go back to normal. If the bone is affected, then the chances of the tissue to go to the normal is really minimal.
Does recession always related with bone loss?
We can say that, yes, because if we go back to our normal anatomy, there is fenestrations and dehiscence. And when the patient have these bone anomalies, they are more prone to recessions. You don't see recession with a bone on the area unless it's a defect you make it for a research or something. But usually recessions, you see the root surface. The moment you see the root surface, there is no bone on that area. So that's no bone on the area. There's nothing we can do. And that's where we come, if you remember the basic anatomy, dehiscence and fenestration. Recession are always with cases of, comes with cases of dehiscence.
اوكي شكرا دكتوره ما قصرتي. نقدر نكمل الكورس. بالنسبه للي باقي ما جاوبنا على اسئلتهم بتكون ان شاء الله في نهايه الكورس. تفضل يا دكتور.
Okay, thank you, and thank you for your interesting questions. So we'll move on to the last bit of the classification, which is implants. So this case has an implant over here. This is an implant here. So this is a healthy implant with a healthy tissue. With implant cases, we have two criteria: success and survival. Survival means the implant is only there. Success, the implant is there with excellent condition. And to measure the success, actually, there are many factors we need to measure them, which is the mesial papilla, the distal papilla, the zenith of the gingival margin, the convexity of the area, and the texture and color of the tissue for that area, the amount of keratinization on that area. All these will consider as a healthy implant. We need to know what's healthy, what's good implant. Because if patients come to you for maintenance, you need to know what's good and what's bad, what's the problem and what's not. You need to check the pink aesthetics, the white aesthetics. The pink aesthetics is the one I just talked about it, which is about the papilla, the textures and everything. The white aesthetics is related to the teeth shape and form and texture and translucency. So pink aesthetic factor, you need to measure them, you need to see them. Some patients get really picky and they tell you, oh, I have some bone loss on the area, the tip of my papilla is lost on this area. So you need to know, okay, this is an excellent healthy implant. There is a small defect. We can address this defect. We will refer you to the implantologist to check what's going on the area. So, and usually picky patient, they are really stressful during the clinic, but honestly, they are the patient which makes you the best dentist because they are so picky and you want to make the best for them so you can diagnose even better and see what's really going on with the patient. So check the implant, check the bone, check the x-ray around it, check the probing depth around it, check the soft tissue around it. If everything is healthy, you need, as a general dental practitioner, know what's healthy. So if you know what's healthy, you can reassure the patient and maintain the case as it is. If you can detect any problem around it, it needs immediate attention and immediate referral because things will go really bad around implants. We cannot afford it. It's hard to treat it. So the earlier we diagnose it, the better the outcome will come for the treatment. So this is a healthy tissue. This is successful. If it is survival, that means the implant is there. So in some studies, you said, we have 100% survival rate. Okay, the implant is there, but you don't know how good is the implant there. So you need to know how good is the implant, there. You need to know that the implant is there in a good condition. So this is successful. You need to know that. You need to measure all the measurements on the area, and then you build on that. Moving on, the second category of the implant is premucositis, is when only the soft tissue, it's the equivalent of gingivitis, where only the soft tissue affected, not bone affected on the area. And that's really related due to the prosthetic. It wasn't done properly. It was over-contoured, it wasn't prepared. It's just done in an unprofessional way. And that caused really gingival defect on the area. And you can see how funny it is that the soft tissue take exactly the defect, the shape of the defect area. The moment we removed the crown, clean it up, adjust it, do it in a proper way and put it back, the gingiva growed back in a normal position. Sometimes it happens if we have plaque related factors like calculus on the area, but it happens all the time. We need to keep an eye on it. It is something we don't want it to progress. We want to treat it as early as possible. So these things happen, yes. These are pre-implant problems, premucositis. You need to diagnose them the first thing. You don't need to panic when you see these things because it's only on the soft tissue, not on the bone, and it's early diagnosed. And as soon as you refer it, it would be treated as soon as possible and things go back to normal. So when we have pre-implantitis, this is where we have bone loss, and it's mainly due to bad oral hygiene. And you can see here as well, the calculus takes the shape of the implant surfaces. The problem is with cases, with patients, they always think if we have implant, we will never have problem on it. So just remove my teeth because I had a lot of problems, I struggle a lot of them, and put an implant on them, and then things will be better. Actually, no, things will not better. If you cannot keep your teeth, you cannot keep your implant. And I always tell my patient, إذا أنت ما قدرت تحافظ على الأسنان اللي ربي خلقها لك، ما راح تقدر تحافظ على الشيء اللي أنا بحط لك إياه. As long as the patient gets that point, then we can place implants for the patient. Usually patients come to the perio-clinic with really deep, severe problems, and they want to save their implants because they paid a lot of money to saving them. But actually, they could save their implants just by brushing their teeth. Well, if the implants was properly placed. So these defects, unfortunately, are really common. Oral hygiene are really bad in these cases. It's just because we rush, and some doctors, we rush out and place implants without making sure that the patient is under good maintenance program. Patients sometimes will stay as long as they having dental visits under excellent oral hygiene, and once they are on maintenance, they just neglect their oral health and come back like this, unfortunately. So there are many factors that related to it. We need to diagnose this problem. Is it only soft tissue? Is it soft tissue and bone? For treatment of these cases, it depends on how much bone is lost around the implant. If it is more than half of the implant bone loss, then it has a different modality. If it is less than half, we can do bone graft. It depends on the around, if it is all around the tooth, or if it is only on some local area on the tooth. So these are factors affecting the treatment quality, but or the treatment outcome. But we need to know the diagnosis on the first place. And in the last category of implant is loss of soft tissue and bone on the area. As you can see, this case is really disaster. I can see the implant through the soft tissue. There is no good soft tissue on that area. There is no good bone on that area. The implant, there is many problems in that area. The patient should have adjusted her occlusion before having the implant placed on the area. And the disaster is the implant is even placed in a higher position. So all this is soft tissue loss. So we are losing soft tissue, we are losing bone, there is no bone. The implant is in the wrong position. And the patient, unfortunately, this patient come to the clinic and tell you, yeah, can you put for me soft tissue graft and treat the soft tissue? It's not a soft tissue problem. It's, if we diagnosed it right, it's an implant problem with a defect of a bone and soft tissue. So we don't take the soft tissue as an isolated diagnosis. We need to diagnose what's really the problem is. We need to know exactly where to tackle the problems. So for this final category, we can say the pre-implant condition, it's pre-implant health. So if patient come to you for a diagnosis and patient have implant, like the first case and the last section I showed you, it's a pre-implant health. If the patient have a mucositis effect, we say pre-implant mucositis. The diagnosis would be pre-implant mucositis. If the patient have loss of the bone around the implant, it's pre-implantitis. If the implant tissue have loss of soft and hard tissue and there is defect on the area, the diagnosis would be pre-implant soft and hard tissue deficiencies. And by that, we covered up all the diagnoses. So I'll just sum it up on one slide so you can remember it and recap it. First, we went with the gingival category and what's healthy, and then with the periodontitis, and then with the manifestation of systemic disease, and finally with the pre-implantitis. And now with the last section of the presentation, I will talk about the periodontitis and the stages and the grades of it. Before we move into that last section, if you got any questions, I'm more than happy to take them.
شكرا دكتورة على الشرح الرائع. طبعا في سؤال موجود الآن. When do scarring around the implant, is it affected or there is side effects?
Well, I know the dilemma that goes on that area, but I don't have a problem if you have a metal prop and probe around the implant. Don't get Don't get really distressed if you don't have a plastic probe to probe around the implant. If there is a problem, you will know it. Because if you don't probe, you will not diagnose the problem. It's like لما البيشنت يفكر يقول لك طيب مش السكيلينج بخرب اسناني، بس اذا انت ما سويت سكيلينج راح تخسر اسنانك، ما راح تخرب اسنانك. It's the same case with the implant. If you have a really good soft tissue attachment, if you place the probe, there is no harm on it. If you have a loose attachment and you have a problem, you need to probe to diagnose the problem, and you will see that problem. So you have to probe, because if there is no problem, you cannot probe it. It would be nice. Unless you have a tissue level implant, that's a different story, because you will have some probing depth on the area, but it's fine up to 5 millimeters around the implant. If you are not sure, or you are worried that you will traumatize the case, or you are in doubt of it, always refer. Please don't hesitate to refer the patient. If you don't know, just send the patient, tell them, I don't know, I'm not sure. Ask your periodontist or the doctors you are dealing with, or the implantologist who's following up the cases, and they can tell you, so you'll have an idea how things are going on. But please don't express yourself as, oh, I will not do it, so I will not harm it. If you don't do it, you will have more harm done.
طيب دكتورة، مريض لديه انحسار لثوي في الأسنان السفلية الأمامية أكثر من 3 أو 4 تقريبا، علما أنه في good oral hygiene. So what is the treatment for him?
The treatment depends on the cause. ليش صار له recession أصلا من البداية؟ هل هو بس oral hygiene habit؟ هل هو because of the tooth positioning؟ هل هو because of the periodontal case؟ So إذا كان بس من oral hygiene habits, we need first to change the oral hygiene. Surgeries are variety. We have many periosurgeries to cover the recession. But what's the main cause of the recession should be treated first. For example, إذا البيشنت بس بسبب البوزيشن حق الأسنان وشفنا إنه أقل من 3 ملي، وبالتقويم إذا رجعناه بترجع اللثة تنمو، هنا ما يحتاج أنا أتدخل كجراحة بالموضوع هذا. فيعتمد على السبب أكثر من إنه يعتمد على طريقة العلاج. الجراحات مختلفة، نقدر ناخذ soft tissue graft، نقدر نسوي GTR، نقدر نسوي membranes، نقدر نسوي just coronary advanced flap. There are so many treatment options to do them. Which treatment option depends on the case, the phenotype of the tissue, the amount of keratinized tissue, and the patient willings. Some patient إذا أنت قلت له أوكي عندك هذا recession هو stable ما تغير مثل first diagnosis we said, he can just live with it without any problem. Yes, can you hear me? Hello? Hello, I cannot hear you. I'll just try to contact them. Hello, I can't hear the issue, please. I think there is some connection problems.
دكتورة معاكي والصوت واضح، الله يسعدك. نكمل؟
Okay. Now I will move to the last part of this presentation, which is the staging and grading of a patient. So, first to diagnose the case, we said if the patient is diagnosed with the periodontitis, which is the first, with the second category, if the patient is diagnosed with the periodontitis, then we have to stage and grade that patient. So first we need to know the diagnosis, then we stage and grade that patient. So what's the diagnosis here we have? It depends on the full mouth probing, the radiograph, and the amount of missing teeth. So once we did that and we come up with the diagnosis, then we can decide which stage and what grade come to the patient. So the stage is really depend on the severity of the disease. يعني الستيج بتعطينا المرحلة اللي فيها المرض. هو ما بيشخص لنا المرض، بيقول لنا في أي مرحلة هو المرض. الجريد يعطينا الدرجة البروجنوسيس اللي فيها هذا المرض، أنا إيش أتوقع بيصير من هذا المرض. فهذين الاثنين هي مش تشخيص، هي بتعطينا بس لأي مدى موصل فيها المرض. So I would know how bad the periodontal is or how good it is, and I know what to expect the outcome for it. So as long as we diagnose it as periodontitis, then we can move on to the stage and grade. So we'll start with the stage لأنه بيعطينا بأي مرحلة وصل الديزيز. And this is really good indicator to know how severe or not is the disease. So for stages, we have 4 stages for the disease. Okay. الstages طبعا احنا قبل كنا بالdiagnosis نقول localized, severe, generalized, moderate, periodontitis كذا. الحين لا. الstages مجرد ما يكون عندنا 4 mm pocket, it's stage 2, or 4 mm attachment loss actually, it's stage 2. So you would say periodontitis stage 2, that's it. You don't say periodontitis stage localized stage 2 on the upper right. No, it's periodontitis stage 2. If you have more than 5 mm pockets, it's either stage 3 or 4. It would never be stage 1 or 2. So you don't need to be so particular on that area, because then you will measure the extent of the disease. Okay. We have the radiographic bone loss, and we can see how much bone loss on that area. We can see as well at which stage is it. So if the bone loss is exceeding the middle of the root, or of the third of the root, it's either stage 3 and 4. There is no way we have it stage 1 or 2. And there is a way to calculate the radiographic bone loss. So if we have, for example, radiographic bone loss, which is exceeding the middle third of the root, and 4 mm pocket, it's stage 3. It's not stage 2. So always go with the higher stage. Stages can be changed. So if the teeth are treated and they're getting better, they can go to stage 2. But if the teeth are not treated, they will stay at that same stage. If you have patients with periodontal tooth loss, more than 500 teeth loss, then this is stage 5. Even if he doesn't have periodontal pocket, it's stage 5. It's periodontitis with stage 5. But usually with periodontitis patients, they have periodontal pockets. But if it is treated, the stage doesn't change with time. يعني مثلا إذا تعالج البيشنت وطاب بس هو لسه خسر 5 أسنان، ما بيتغير التشخيص حقه. هو هذه المرحلة كان واصل فيها في العلاج. فهو هذه مرحلته بالعلاج. في التشخيص بظل إلين ما نوصل لمرحلة إيش اللي نقول فيها؟ اللي هو stable periodontitis. إذا وصلنا لمرحلة stable periodontitis which happen after maintenance، بعدين نقدر نقول إنه it's clinical health periodontium with stable periodontitis. But as long as there is an inflammation on the area, even if the pockets are limited, but there are too many teeth are lost, it's stage 4 immediately. So you go with the higher stage, and it's a stage for all the mouth. It's not like you would say it. The complexity of the treatment, its local factors, these are usually explaining how the stages are. So these, if you want to know in more details, you can read them, but you don't need to worry that you need to know them all. If you know this, basically you are good. You can diagnose the patient very well. So if you want to differentiate in more details, you can have a clue on these patients. Okay. The severity and the extent of the treatment, it's the localized or generalized. يعني احنا قلنا ما نقول localized periodontitis و generalized perio في the same case. لا. إذا عندنا مثلا سن واحد بس اللي فيه bone loss واللي فيه 5 mm pocket, we will diagnose the patient as localized periodontitis stage 4. طيب إذا عندنا الستيج هذا على الأسنان كلها أو على أكثر من 30% من الأسنان, we will diagnose the patient as generalized periodontitis stage 4. That's it. حتى لو أسنان ما كان فيها أي مشكلة, ما نرجع نقول لا بس هذا السن ما في مشكلة وكذا. لا, it's the diagnosis. each tooth diagnosis had a different story. This is the general diagnosis, this is the diagnosis. في عندنا ثلاثة patterns للdiagnosis اللي هو localized والgeneralized والmolar incisor. إذا عندنا مثلا bone loss بس على المولرز والincisor, we said periodontitis stage 4 molar incisor pattern. Okay, so it's either localized periodontitis stage 4, generalized periodontitis stage 4, or periodontitis stage 2 molar incisors pattern, for example. So you need to know this very well because this will help you in diagnosis. You need to understand this because it will add to your knowledge on it, and then you need to check the extent. But you don't see, say, 2 diagnoses in one patient. البساطة في هذا الكلاسيفيكيشن انك خلاص هو diagnosis واحد للبيشنت، فانت ما تعقد التريتمنت، فانت تعرف تشخيص المريض اللي هو نصف العلاج، اي درجة وصل فيها المريض، فانت تعرف هل انت تحول مريض ولا لا. Usually patient مجرد ما تشخصه stage 3 or 4 immediately refer the patient. With stage 1 and 2 you can manage them, but don't try to be heroic with these 2 stages. So these are things you need to really put in mind. Refer the patient in advanced stages. You can manage the patient in minimal stages. This stage considered as mild case. These stages considered as moderate. Stage 3 is severe and stage 4 is extremely severe cases. So in severe and extremely severe cases, you need to manage them. In mild and moderate cases, you need to refer them if you are not sure of, or if there is a multidisciplinary factor on the area. But if it is only calculus related or plaque related, I'm sure you can manage it very well. So these are with the stages. So we are clear now, hopefully, that after we diagnose the patient and we know the probing depth, the radiographic measurements, we can either depend on the clinical attachment loss or on the radiological bone level loss and stage the patient accordingly, or we can use the number of teeth present in the patient's mouth as indicator as well. So these are really important to remember in stages. So it's as simple as periodontitis, and then which stage is it? Okay, it's simple stage. What's the cause of the treatment? It's calculus or plaque. We can just manage it by scaling and treat it. Now, what stage is it? Stage 3 and 4, even if it is due to plaque and calculus, just refer the patient for proper treatment, because usually these severe cases need more advance. And moderate cases, if you have recession with the clinical attachment, it's not only pocketing, and the patient wants to do something about the recession, and you are worried that the patient has thin phenotype, just refer the patient for managing these cases. So basically, stage 1, I'm trusting that all the general dentists, all the hygienists, everyone can manage these cases. With more advanced stages, you need to refer the patient. So that's with staging. So staging really depends on confirming the clinical attachment level, the radiographic bone level. As we said, that moderate to severe periodontitis are stage 3 to stage 4. These are really cases that you need to refer them. But for the mild periodontal, mild to moderate, they can manage stage 1 and 2, stage 3 and 4, moderate to severe periodontitis. As I said, stage 2 could be overlapping, could be moderate stage. You might refer it or might know. You know all the risk factors, you know how to diagnose this. So these stages, you need to assess them and see how it goes with you. And always, I can't stress more on it. If you are not sure, just refer the patient. So for the last step for the treatment is grading. The grading is the prognosis of the treatment. It doesn't give us any information about the diagnosis for the treatment. So what we are expecting from the treatment. So we can check the radiographical bone loss or the clinical attachment loss. And there is an equation to calculate it. I will show it to you later on. So once you calculate that and you see the age of the patient, and this really depends on the maintenance. That means you've seen the patient over the years, over the time. So if you see the patient there, you would know on which category they fit. Phenotype is affecting the prognosis, as we said. If they have really thin phenotype, they would really have grade C prognosis because there is rapid rate of progression. So we need to know how fast is it. If we have a really young patient, like 20 years old with severe periodontitis, then this is a rapid progression because they shouldn't have it. Or there is a minimal amount of plaque. This is a rapid rate of that. So that's definitely grade C. And the other part of it is the grade modifiers. As we speak before, it's this hemoglobin of the diabetes and the cigarette smoking. The higher the patient smoke, the greater the grade. Patient ياخذ معسل ياخذ شيشة على طول grade C. طيب الديابيتس uncontrolled diabetes يقول تراكم عندي 8 7 ما أذكر متى آخر مرة. This is grade C. This is not something you would expect. So if you have a patient that it's diabetic and مثلا نقول عنده pocket 5 millimeters with bone loss, the diagnosis بيصير periodontitis stage 4 grade C. اوكي اذا كان في سن واحد بيكون localized periodontitis، اذا كان في اكثر من سن بيكون generalized periodontitis grade 4 stage C. واذا نبغى نصير more accurate بالdiagnosis ايش نقدر نقول؟ نقدر نقول periodontitis as a manifestation of systemic disease stage 4 grade C. Okay, so I hope that's clear for the stages and grades. So by the end, this is the calculation of the radiographic bone loss. So you need to measure the percentage of the root length and multiply it by 100 and divide that by the age of the patient. So the age of the patient will come. يعني إذا أنت ما قد شفت البيشنت من قبل، هو ما يجيك في regular diagnosis في regular maintenance، أول مرة يجي العيادة أو عمره صغير، you will know the amount of bone loss من عمره. يعني بتقول لا هذا مرة كثير البون لوس في هذا العمر يصير، لأنك بتسوي الريسك فاكتورز لازم مانجت. مثل ما قلت لكم في ريسك فاكتور ثاني مثل الاوستيوبروسيس، الهايبرتنشن، but these two are the major risk factors. smoking, diabetes. الريسبونس حق السكيلينج اللي قلت لكم اياه، مثلا انت بعد اسبوعين سويت للبيشنت سكيلينج روت بلاننج، جالك بعد اسبوعين ما طاب، هنا جريد سي تحوله على طول. بس اذا طاب بتعرف انه اوكي جريد اي كان بس سكيلينج وروت بلاننج والاماونت كل شيء. فالجريد really it doesn't add to the diagnosis, it gives us an idea about the prognosis. So that's all about the staging and grading, and by the end a periodontitis patient is a periodontitis patient for life. فإذا أنت عندك diagnosis, that diagnosis will fit with the patient for the rest of its life. It will not change, it will never change. This is the way that it's examined, and we need just to maintain the patients throughout it and see if the patient will get worse or get better about it. And the stages will never change unless it's localized, local factors treated, then we can change it. Otherwise, it will stick with the patient as a stigma for the rest of his life. So that's it for today's presentation. Thank you all for listening. If you got any further questions or concern or anything put in your mind, these are my contacts. Feel free to contact me on direct messaging. I'm more than happy via any way that helps you. If you got any questions regarding the last part of the presentation, I'm more than happy to answer all your questions.
شكرا لك دكتورة على الشرح الرائع، صراحة كان شرح مبدع جدا، ونعتذر من الجميع عن الخلل اللي صار في الإنترنت. عموما عندنا استفسارات طبعا أنا مأجلها لنهاية الكورس، من بينها هل الأورجانيك فودز له أثر في العلاج؟
أنا مثل ما قلت لكم النيوتريشنز اللي well established اللي هو فيتامين سي وفيتامين بي 12 هم اللي يأثروا. طبعا الفود in general either organic or non-organic، الهيلثي فود، الريسنت ريسيرش، وهذا اللي الحين في اليوروبيان فيدريليشن يبنون عليها، البيشنت لازم ياكل 5 سيرفنت من الفروتس اند فيجيتابلز لانه يقلل الريسك اوف اورال كانسر. الاورال كانسر هو جزء من الدايجنوستس اوف periodontal problem، هو جزء من الدايجنوستس for any dental problem we need to diagnose it. فاذا البيشنت ياكل خضروات وفواكه باستمرار بيقلل الريسك حقه. إذا البيشنت أصلاً عنده unhealthy dietary habits الاميونيتي حقته تقل، الريسك فاكتورز حقه يزيد. There is a higher chance to develop oral cancer. Well, actually, in the UK, they have a study that proves that patient who eats 5 servings of fruits and vegetables a day had higher chances to develop oral cancer. So yes, it's a fact. Whether it's organic or not, it's not that much important. What is important that the patient is eating healthy. مثل ما قلت لكم البوليميك، الانوركسيك بيشنت، البيشنت اللي سووا لهم تكميم للمعده، اللي ما ياكلون اصلا كويس، هذول لازم ننصحهم ياكلون عصائر او اشياء خضروات سائله، لان هذه الاشياء بتساعد اللثه حقتهم، لان هذه من الدياجنوستس عندنا اللي من البدايه ناقشناها تاثر. ايوه تاثر هذه الاشياء. كم مدى تاثيرها او ايش مدى تاثيرها؟ وكلنا نعرف قصه البحاره اللي ما كانوا ياكلون برتقال وخسروا كل اسنانهم لانهم صار عندهم فيتامين سي ديفيشنسي سكيرفي ديزيز. فلذلك هذه الاشياء هي مهمه تضيف للمريض، بس مش اشياء اساسيه، يعني ان بس نعتمد عليها بالدياجنوسيس. فاذا كان هو التشخيص الوحيد هو المشكله الوحيده we have to treat it. بس اذا كان مثلا يقول للبيشنت خلاص انا بس باكل خضروات وفواكه بتصير لثتي اقوى، لا، هنا we need to stop and see what's going really on with the patient.
تمام. كويس جدا دكتورة. بالنسبة أي شخص حاب يتناقش مع الدكتورة بإمكانه يختار خانة رايس هاند، وإحنا بنفتح له المايك بإذن الله عشان يتناقش مع الدكتورة. دكتورة عندنا سؤال أنا مأجله للنهاية يعني.
تفضل.
إيش رأيك عن الجنجايفكتومي؟
عن إيش؟
جنجايفكتومي.
الجنجيفكتومي مثل ما قلت لكم بالبداية، الجنجيفكتومي يعتمد على الفينوتايب. إذا كان thick phenotype even وأنت trained as a general dentist وعندك thick phenotype و you know how to do it, just do that for the patient. إذا كان البيشنت أصلاً ما عنده مشكلة، يعني أنت تشوف إن الجنجفة نازلة بس أنت يدك تحكك إنه لا you need gingivectomy، بس البيشنت ما يعاني من مشكلة في هذه، خلاص مو لازم تسوي للبيشنت gingivectomy. بس إذا البيشنت لا he has a gummy smile, he needs a gingivectomy on that area, it's always good to do that for the patient.
تمام، شكرا دكتورة، ما قصرتي. بانتظار اللي حاب يتناقش مع الدكتورة يضغط على خانة رايس هاند. تمام. اللي حاب يتناقش معاها فويس. أي أحد حاب يتناقش مع الدكتورة فويس يختار خانة رايس هاند وإحنا بنسمح له يتكلم معاها مايك. بانتظاركم أي شخص حاب يتناقش مع الدكتورة إحنا بانتظاره. أعتقد دكتورة المحاضرة كانت واضحة جدا لهم، فلذلك ما أتوقع إنه أي شخص حاب يتناقش، لأنه صراحة ما قصرت دكتورة، كان شرحك رائع جدا صراحة، كلنا استفدنا من هذا الشرح الرائع، ونتمنى إن الكل استفاد من هذه المحاضرة. في شخص حاب يتناقش معك دكتورة؟ أوكي. طيب يا عباس، المايك مفتوح، بإمكانك الآن تتكلم. تفضل أخ عباس. أخ عباس تفضل. افتح المايك من عندك.
السلام عليكم.
وعليكم السلام ورحمة الله.
يعطيك العافية دكتورة. عندي سؤال بسيط، شنو علاقة الجهاز المناعي بالتهابات اللثة؟
هذا سؤال جدا جدا مهم، أنا ما تطرقت عليه كثير بالبرزنتيشن، شكرا لك أخوي على هذا السؤال. الجهاز المناعي له علاقة بالتهابات اللثة. احنا عندنا مقولة تقول الفم مرآة اللي يصير بالجسم، فإذا المناعة الجسم ضعيفة بتتأثر اللثة على طول. أصلا ليش الناس اللي عندهم السكر في خطر أكثر من اللثة؟ لأن مناعة جسمهم تقل. التهابات اللثة هي عبارة عن توازن بين دفاع الجسم وبين البكتيريا اللي موجودة. فإذا البكتيريا صارت أقوى من دفاعات الجسم تزيد عندنا التهابات اللثة. إذا كانت مناعة الجسم قوية طيب فحتى لو زادت كمية البكتيريا الجسم يقدر يدافع عن نفسه ويحمي نفسه من الالتهابات. فالعلاقة جدا جدا وثيقة. طبعا في أمراض كثيرة بسبب نقص المناعة تبين عندنا باللثة. في الأدوية المثبطة للمناعة برضو تأثر على اللثة. فالمناعة جدا جدا مهمة، لأن أصلا في بعض النظريات اللي من نظريات أسباب التهاب اللثة أو تكون التهاب اللثة، اللي هو الموازنة بين مناعة الجسم اللي هو البالانس بين الإميونولوجي والبكتيريولوجي. فإذا البكتيريولوجي فازت، إيش اللي بيصير؟ إذا كفة البكتيريولوجي رجحت بيصير periodontitis. إذا في كفة الإميونولوجي رجحت بيطيب البيريودونتايتس. فإت has really strong relation to it. صحيح.
حلو، فهمت. ممكن شغلة ثانية بس بخصوص الموضوع؟
تفضل.
دام فضلك. في شغلة هم سامعها أن بالتهابات اللثة عادة الجهاز المناعي هو اللي يهاجم اللثة مثل الأوتوميون كونديشنز، فهل هذا صحيح بخصوص التهاب اللثة؟
هل هذا صحيح أو لا؟ ما نقدر نقول 100%، بس في أبحاث كثيرة تدعم هذه النظرية. هذه من النظريات، يعني في نظريات كثيرة حول سبب تكون أمراض اللثة، وهذه إحدى النظريات الموثوقة يعني. فصحيح كلامك، المناعة جدا مهمة وهي إحدى الأسباب، بس هل هي السبب الرئيسي أو السبب الوحيد؟ ما حد يعرف. ما حد يعرف إلى الآن، ما حد يعرف.
يعطيك العافية، مشكور.
اوكي، شكرا دكتور عباس. استفسارات كانت رهيبة. والآن وافي، عندك المايك، بإمكانك التحدث مع الدكتور. تفضل دكتور وافي.
السلام عليكم.
وعليكم السلام ورحمة الله.
في البداية شكرا دكتورة وشكرا للإخوان المنظمين. دكتورة، عندي سؤال بخصوص المرضى الضغط ومرضى السكر. إذا جون العيادة مثلا، إلى وش النورمال رينج اللي أقدر أعالج مريض السكر فيه أو مريض الضغط؟ ستاندر، الشيء اللي يعني عادي مو مشكلة إني أقدر أعالجه.
صحيح. في شيء عندنا احنا نورمال ليفل، وفي شيء عندنا هاير نورمال، يعني بس في الرينج. فمثلا الضغط احنا عندنا النورمال رينج 120 فوق 80، صح؟ البيشنت يقول لك انا دايخ، انا مو كذا. انت بتقيس ضغطه قبل ما تبدا، بتشوفها 140 على 90 كذا. it's still it's high blood pressure، بس تقدر تعالجه. الدايابيتس patient they never come in a normal، دائما بيكون مرتفع شوي الدايابيتس عندها. فانا ايش اسوي مع هذه البيشنتس؟ دائما تخليهم اول بيشنت باليوم ويجونك ماكلين كويس وماخذين ادويتهم، الا انهم بيكونون نيو بيشنت جايين لك. فهنا you need to assess the patient in general. اول ما يدخل العياده هو يقول لك والله ضغطي مرتفع، انا تعبان، انا كذا، لا تحط يدك في البيشنت. لما يجي البيشنت لا يقول لك انا كويس، هو مرتفع بس هو دائما يرتفع وانا قاعد احاول وانا بالعلاج وكذا، هنا في هذا الامرجنسي you need to treat him و you need to prompt the patient انه انت ما راح تطيب بس بالعلاج اللي انا اسويه. جزء من علاجك ان نتحكم بالسكر، لان انا لو عالجتك وضبطت لك كل شيء والسكر حقك مش مضبوط راح ترجع عندك مشاكل اللثه مره ثانيه. ف you need to know your patients, you need to treat your patients، بس don't risk it. يعني it's not worth انك انت تشوف ضغطه مرتفع والبيشنت يقول لك انا تعبان، لأن مع الستريس، مع التعب اللي زيادة they might faint, they might have complication. Part of the management, you need to be proactive. You don't have problems. You don't want to have problems in your clinic. Yes. Part of the patient's management, أنت لازم تعرف أنا متى أحط يدي في البيشنت. فإذا البيشنت قال لك أنا ما أبغي أو أنا تعبان أو كذا، حتى لو أنت تدري إنه أوكي لو بتشتغل له emergency أو كذا، لا تشتغل. قول له خلينا نريح، تعالي يوم ثاني تكون متغدي كويس، ضغطك افضل وكذا، وانا حاضر اللي تامر فيه بسوي لك اياه. اذا بيشنت مثلا دايابيتيك يقول لك والله انا ضرسي يألمني بس انا تعبان، لسه ما اخذت ادويتي، لسه ما سويت شيء، تقدر تقول للبيشنت اوكي تقدر تاكل لك شيء بسيط، I will reschedule you later، خذ ادويتك ارتاح وتعالي مره ثانيه. اذا البيشنت قال لك انا اوكي وانا دائما يرتفع شوي واحاول اندر كنترول وتشوفه انه he's same patient and he knows what he's doing, then you need to treat the patient. You cannot just dismiss all your patients just because انه الضغط شوي مرتفع والسكر شويه مرتفع.
يعني نقدر نقول في حالة الهايبرتنشن 140 على 90 it's normal يعني.
It's not normal, it's hypertension.
Yes.
It's on the lower range. بس مثل ما قلت لك إذا أنت شفته كذا مرتفع بس البيشنت شفته أوكي، طبعا أنت لازم تكون حذر بعلاجه، ما ترفع الكرسي بسرعة وتنزله بسرعة بهالطريقة أو تخلي البيشنت بسرعة يقوم أو بسرعة يتحرك، تخليه على راحته لأن هذه الأشياء تأثر في الهايبرتنشن. بس إذا جالك البيشنت 140 على 90 وعنده pain ويقول لك أنا في severe pain و I need treatment و he is good وتقول له مرتفع، يقول إيه أنا على طول مرتفع عندي، تقدر تعالجه. بس إذا جالك 140 على 90 و you can delay the treatment والبيشنت يجي يقول أنا تعبان أصلاً وضغطي مرتفع وأنا جاي غصباً عني وما أدري إيش وكذا، لا be careful, be careful.
Okay, thank you.
So any other questions? Please, if you have any question, feel free. I think there's another net problem. Please let me know if the problem solves or if anyone have any problems.
اعتذر منكم، كان في عندي خلل بسيط في النت. دكتور اويس، المايك مفتوح، بامكانك التحدث الان. تفضل دكتور اويس.
يعطيك العافية دكتورة كوثر.
الله يعافيك.
في الحقيقة دكتورة أبغى أضيف إضافة بسيطة على سؤال الأخ قبل شوية، اللي هي نقطة نبغى يا دكتورة تتكلمين لنا شوية عن البروفيلاكسز اللي بنستخدمها مع مرضى اللي يعانون من كاردياك ديزيزز أو مثلا عندهم بروستاتيك فالفز مثلا. والجزئية الثانية دكتورة اللي هي في علاقة بين الكاردياك ديزيزز أو some cardiac diseases والجنجيفال انلارجمنت أو ريسيشن أو غيرها يعني. وشكرا، يعطيك العافية.
شكرا على سؤالك، سؤال جدا جدا مهم وممتاز ورائع. في علاقة جدا وثيقة بين الكارديوفاسكولار بروبلمز والبيريدونتايتس. As I said before إنه الميرور is reflection what's going on in the body. الفم مرآة باللي قاعد يصير بالجسم. I have many patients referred from cardiology because they have some gum problems. So the matter of fact إنه patients اللي بيروحون بيسوون heart surgeries or open heart surgeries, they refer them to periodontal clinic for cleaning لأنه البكتيريا اللي تسبب periodontal problem ممكن تسبب بكتيريا اندوكاردايتس. فاحنا لازم نخلي البيشنت يكون كلير وفمه مره ممتاز ونظيف قبل ما يروح للهارت سيرجري. سو الريليشن مره كبيره بينهم. من ناحيه البروفيلاكتيك انتيبيوتيك over the last 5 years الجايد لاينز حق الكارديولوجي والبروفيلاكتيك تغيرت يمكن 3 مرات. يعني 3 مرات احاول ابديت ماي نولج، تغير شيء زاد شيء نقص.
دكتورة المايك تقفل عن إذنك.
So سمعتون البارت الأول لما قلت عن الكارديولوجي والبريودونتال؟
عيديها من جديد.
Okay, so usually a cardiologist or a patient with cardiology problem, they have periodontal problem. There is a strong relation. مثل ما قلنا من قبل إن الفم مرآة اللي قاعد يصير بالجسم. طيب البكتيريا اللي تسبب البيريودونتايتس هي نفسها البكتيريا اللي تسبب اندوكاردايتس. فلذلك البيشنت قبل ما يروحون للهارت سيرجري يخلونهم يسوون كليرنس بالبيريودونتال، يسوون سكيلينج، يسوون اكستراكشن، لأن ما يبغون هذه البكتيريا تنزل وتأثر على البروجنوسيس حق السيرجري. and it's vice versa. طيب فهو صحيح يأثر مع بعضه، مقدار التأثير يختلف، إذا في بلاك بيكون أقوى التأثير وكذا. أي سيستميك ديزيز يأثر على الموضوع، الكارديولوجي بالذات يأثر مرة كبير على الموضوع. بالنسبة للبروفيلاكتيك أنتيبيوتيك مثل ما قلت لكم قبل شوي، في ال5 سنوات الأخيرة تغيرت الجايد لاينز 3 مرات. هل نعطي هذا البيشنت، هل هذا يستحق أنتيبيوتيك أو هذا بيصير أوفرلود في الأنتيبيوتيك؟ To be on the safe side, honestly أنا أكتب لتر للكارديولوجيست أسأله، ما فيها شيء الواحد يسأل. I just refer the patient back to the cardiologist. هل هذا البيشنت حالته تستدعي إنه أنا أعطيه أنتيبيوتيك؟ أنا التريتمنت اللي بسويه مثلاً في جراحة، في بلاد، في اكستراكشن، أو التريتمنت اللي بسويه بس سكيلينج، ما في بلاد سيفير وكذا. إذا البيشنت usually severe or extensive, it's always better to give him antibiotic. If you are not sure and it's simple procedure, it's never harm to ask the doctor. Usually patients اللي يجون عندنا محولين من المستشفيات الحكومية، من المستشفيات التخصصية، عندهم ورقة مكتوب فيها في حال علاجات الأسنان الجراحية بيحتاج مضاد حيوي، وحتى اسم المضاد محددين لهم. بس في أغلب الحالات إذا مش محددين وأنت مش متأكد هل هذه الحالة تستدعى أو لا، أنا أغلب الحالات أرجعهم على الكارديولوجيست أسألهم بس kindly، أو أتصل عليه أقول له لو سمحت بس أنا بسوي كذا وكذا البروسيجر، هل يستدعي أو ما يستدعي؟ لأن ما تبغي تسوي overload للبيشنت، لأن periodontal patient is a long treatment, it's a lifetime treatment. فأنت مش كل مرة بيجي لك maintenance، أو مثلا بتحطه على maintenance كل 3 شهور راح تعطيه أنتيبيوتيك، أنت راح تضر البيشنت بدل ما تنفعه. فالأفضل أنك تعرف هل يستحق الموضوع أن نعطيه أنتيبيوتيك أو لا.
طيب شكرا دكتور أويس. بالنسبة دكتور خالد رمضان السايح، تفضل.
ايوه، السلام عليكم.
وعليكم السلام ورحمة الله.
شكرا جزيلا يا دكتورة جدا على الشرح الوافي. بسأل حضرتك في بعض الأدوية اللي بتستخدم للمناعة، لجهاز المناعة، في مثلا في زرع الكلى، بتسبب اللارجمنت للجنجفة كبير جدا، أحيانا بيغطي التوس كلها يعني. فأحيانا إحنا بنعمل جنجفكتومي ويرجع يتكون تاني. هل في طريقة يعني أخرى؟ وطبعا هو ممكن المريض ما يقدرش يوقف هذه الأدوية خالص وهو يعني في الفترة الأولى للزرع، فإيه اللي ممكن يحصل فيه تصرف في الوضع دوت؟ يعني الجنجفال انلارجمنت لما يكون كبير ومتكرر، وبعد الجنجفكتومي بيحصل تاني ريكارنت للجنجفة.
صحيح، سؤال ممتاز.
دي حاجة، دي نقطة. ممكن أسأل تاني ولا؟
أيوة تفضل تفضل.
والله حضرتك في لما يكون في البريودونتال ابسس وكبير، هل كل حالات البريودونتال ابسس ممكن كنترولد، يعني ممكن تتعالج، ولا في بعض الحالات اللي نقول لا خلاص ده هوبلس كيس وبعدين تحتاج لازم اعمل اكستراكشن مثلا؟ ايه الحد اللي اوصل بيه ان اقول لا خلاص انا اعمل اكستراكشن اذا كان يعني فيه؟ وتاني حاجه بنسال على الجوفينايل بريودونتايتس، يعني لو نبذه على الجوفينايل بريودونتايتس. شكرا يا دكتوره جزيلا.
شكرا على أول شيء بالنسبة لسؤالك على الجنجيفال انلارجمنت، صحيح في كثير بيشنت ما يقدرون يوقفون أدويتهم، بس في أدوية بديلة. ف it's always worth to write to their doctor، لأن إحنا ما ندري الدكتور، وأغلب الدكتورز الميديكال they don't know that it has a gingival side effect. I mean, it's their least worry to know about the gingival side effect. So if we write a note for the doctor, they put it in their attention. فاما انهم يبدلون الدواء او يقللون الدوز. في بعض الحالات صحيح ما يقدر البيشنت يبدل الدوز، ما يقدر يغير الجرعه، هو هاير. احنا ايش نقدر نتحكم فيه؟ نقدر نتحكم بالاورال هايجين، لانه يقلل الريسك حق الاوفر جروث. فانا البيشنتس اللي ما يقدرون يغيرون ادوياتهم واللي هاي ريسك حق الاوفر جروث اجين، اقول لهم يسوون كل شهر سكيلينج، لانه هو ما راح يصير فيه اوفر جروث، هو رياكشن على البلاك اللي بيكون موجود. فاذا احنا حافظنا على اكسلنت اورال هايجين والرياكشن قل، بنقلل من سرعه البروجريس ريت. ستيل بنحطه بجريد سي لانه there is a higher chance for recurrent rate، بس it means we need to manage it well. انه we need to manage الاورال هايجين. لازم تقول للبيشنت كل شهر يسوي سكيلينج ولا بيرجع مره ثانيه. اتليست يسوي كل شهر كليننج احسن من انه يسوي كل 3 شهور جنجيفكتومي. هذا شيء. شيء ثاني we need to be more aggressive in our gingivectomy عشان نضمن انه ما يصير فيها recurrence. يعني حتى if we lost the interdental papilla ونخلي البيشنت ينظف in between the teeth, it's better than to keep the papilla والبيشنت ما يقدر ينظفها, which would be the first area affected by the gingival overgrowth. It's a risk benefit balance مرة ثانية. لازم نشوف ايش البيشنت بيستفيد من هذا وايش البيشنت اللي بيضر من هذا. بالنسبة للسؤال الثاني, yes, periodontal abscesses can always be treated. Extraction, in fact, is a treatment option. Okay, فإذا كان tooth unrestorable وفي periodontal abscess or it's not strategic tooth, then we should consider extraction the tooth. بس مجرد إنه في periodontal abscess وmobility للtooth ونقول خلاص نخلعه, we should see and do more extensive examination, see the strategic, see الاوتكم حق التريتمنت. انا اذا سويت لك كم راح يضيف للبيشنت, كم عمر ممكن يعيش هذا التوث, and then decided. But extraction is a treatment option, it's not like removal. بس انه ليش we extract the tooth is the periodontal abscess usually in soft tissue. It's rarely affecting the bone unless there is a severe destruction on the area or endo involvement. In these cases we need to check how strategic is the tooth. Is it worth to save the tooth or not, and then we decided. بالنسبة للجوفينال periodontitis خلاص انتهى. مع الكلاسيفيكيشن الجديد ما نتكلم عنه مرة ثانية. خلاص إذا patient عنده هذا النوع من periodontitis يصير الكلاسيفيكيشن حقه periodontitis stage 3 or 4 or whatever stage with molar incisor pattern. احنا ما قلنا عندنا localized pattern, generalized pattern, molar incisor pattern. فالجوفينال يصير with molar incisor pattern. That's it. There is no need to give names for that. It's all periodontitis. It's all under the category periodontitis. طبعا لأنه aggressive, لأن العمر بيكون صغير مثلا أو juvenile, الجريد C بيصير أعلى, فيصير مثلا periodontitis grade 4, molar incisor pattern grade C. That's the diagnosis.
طب على
شغل المايك من عندك دكتور خالد لو سمحت.
طب بالنسبه للتريتمنت بتاع الجوفينايل بريدونتايتس, هو نفس التريتمنت مثلا بتاع البريدونتايتس في الجريد 4 ولا له يعني؟
Well, we still stick under the all treatment protocol. Well, I personally still do the treatment, give the antibiotics, and go with the same treatment plan. I haven't changed the treatment modality. يعني though the name, the diagnosis have changed, but the treatment modality really, I still, لأن the studies are proven إنه antibiotics help in these patients. So I always go with the same treatment modality.
Thank you دكتورة. شكرا جزيلا.
يعطيك العافية.
شكرا دكتور خالد. الآن دكتور عبدو, عندك المايك وبإمكانك تشغل. تفضل دكتور عبدو.
طيب السلام عليكم ورحمة الله وبركاته. شكرا يا دكتور, يعطيك العافية, وشكرا لكل المنظمين على هذه المحاضرة. بس عندي سؤال بسيط, ايش الفرق او ايش كيف اقدر افرق بين الجنجيفال ابسس والبيريدونتال ابسس, وهل هي نفسها الناق والناب ولا لا؟
هل هي نفسها ايش لو سمحت؟
الناق اللي هي نيكروتايزنج السيرتيف جنجيفايتس والنيكروتايزنج السيرتيف بيريدونتايتس, هل هي نفسها ولا لا؟
لا, هي مش نفسها. النكروتايزنج موضوعها ثاني، مثل ما شفت الصوره. الجنجفة تصير نكروسس، تصير ميته، يصير فيها كانها غرغرينه. طيب الابسس يطلع خراج من السن، يطلع البس اللي هو السائل الاصفر هذا من الاسنان. كيف تفرق بين الجنجفال ابسس والبيريدونتال ابسس؟ على الاماونت اوف بون لوس. اذا كان مثل ما دوبي قلت لدكتور خالد، اذا كان عندنا severe bone loss بالاريا وفي distraction في deep pocket on that area ونشوف بالاكس راي there is bone loss, this is periodontal abscess and usually is combined with endodontic lesion. اذا كان عندنا بس بالتيشو وانا ادخل بس البوكت واخذ الاكس راي ما في bone loss، طيب هذه mostly gingival abscess. وهذه غالبا تشوفها في الكيسز مثلا البيشنت يكون ماكل شيء وانحشر له بين اسنانه وسبب له ابسس، او بقايا سمنت بعد فيلينج حطه، بعد كراون حطاه او كذا. فغالبا هذه الكيسز في الجنجيفال ابسس تشوفها. بس الكاتنج ايدج اللي هو البون لوس اللي انت تشوفه بالاكس راي يعني.
طيب دكتور، هل انا كجي بي اقدر اعالج الجنجيفال ابسس والبيريدونتال ابسس ولا لازم احولها للبيريدونتست؟
Gingival abscess you should treat it as a GP. لما البيشنت يجي شيء محشور عنده actually الابسس you should open it. You never let the abscess، لأن إذا خليت الابسس يصير أسوأ. فدائما إذا عندك abscess افتحه. فإذا عندك absess فتحته نظفت المكان، قول للبيشنت إذا أنت شايف إنه severe والبيشنت compromised واتس multiple، قول له خلاص أنا عالجتك بالابسس، أنا سويت لك كذا، أنا بحولك للأخصائي يكمله. بس إذا gingival abscess انت نظفت المكان، انت شفت الوسخ اللي طلع معك، الابسس اختفى في نفس الوقت لانه نزل، اعطيه اسبوع مراجعه، اذا كل شيء اختفى خلاص ما يحتاج تحوله، انت عالجته خلاص يعني، عرفت؟ بس اذا ما اختفى وظلت المشاكل تزيد هنا لا، هنا لازم تحوله. اذا بيريدونتال ابسس اكيد تبي تحوله لانه في بون لوس اون ذا اريا، فيو ونت تو مانج ات ويل. بس هذا لا يعني انك انت ما تفتح الابسس وتنظفه، دائما الافضل انك تفتحه وتنظفه لانه بيريح المريض. الابسس اذا قعد بينتفخ اكثر، بسبب الم اكثر ويسبب مشاكل ومضاعفات اكثر، وقد تضطر تعطي المريض مضاد حيوي كان هو في غنى عنه لو انت بس اعطيته انستيزيا وفتحت الابسس.
طيب دكتوره، بالنسبه للناق والناب انا كجي بي ما اقدر اعالج صح؟ لازم احول البيريدونتست.
يكون افضل. صحيح.
طيب شكرا يا دكتور، يعطيك العافيه.
شكرا دكتور عبيدة. دكتور عبدو، صراحة كان شرح رائع دكتور كوثر، وصراحة مهما قدمنا من الشكر ما يوفيك حقك صراحة، ولكن نعطيك هدية بسيطة دكتورة كوثر. صراحة تتقدم مؤسسة سما الطبية السعودية بجزيل الشكر والتقدير لدكتورة كوثر الشايب. صراحة ما قصرتي، إبداع، كان جميل جدا والكل انبسط من المحاضرة، وصراحة ما توقعنا أنها بتكون بهذا الروعة، كانت أكثر مما كنا نتوقعه. صراحة شكرا جزيلا لك دكتورة، ونتمنى لك كل التوفيق دائما دكتورة.
يعطيك العافية أستاذ ياس، وأشكركم على هذه الفرصة اللي أتاحت لي، وأشكر الجميع على أنهم أخذوا من وقتهم من إجازتهم الأسبوعية عشان يستمعوا لهذه المحاضرة، وأتمنى أني أفدت الجميع وقدمت لكم الشيء القليل. شكرا لكم جميعا.
الله يسعدك دكتورة، ما قصرتي. بالنسبة للمشتركين، بنزل الآن رابط بالشات تقييم للكورس. صراحة نحتاج منكم كلكم تكونون على علم بالاستبيان، ونتمنى أن الدورة كانت قد المتوقع وأفضل. من كلمتي أنا أقول أفضل مما كنا نتوقع صراحة، وما أتوقع أنه في شخص حيخالفنا الرأي. شكرا لكم جميعا، ونتمنى لكم القادم والأفضل معنا الأكاديمية الطبية السعودية، والسلام عليكم ورحمة الله وبركاته.
عليكم السلام.